Okay, we are all ready, right? All the talks are ready. Yeah. Is there any way of knowing how many are viewing this over the site? Suvita, you can just have a look and let us know. And also
Yes, sir.
any questions which come through.
Yes, sir.
Welcome, Dr. Ajay Krishnan. All right, let's start. So, welcome everybody to our annual Bombay Spine Society conference. Our conference is divided into two parts, and today is the Bombay Operative Spine course part. I welcome all our faculty here. Our hall in charges, Dr. Sandeep Sonone and Dr. Ayush, and Dr. Priyank, who is our moderator today for on this meeting. I welcome all our faculty, esteemed faculty. Thank you for giving us your time and efforts, which will help in teaching us and in all the delegates here. I welcome all our delegates on behalf of Bombay Spine Society. The Bombay Spine Society has a proud tradition in hosting very good academically oriented conferences, and this one, as usual, will also be an academic one. This will be a virtual conference this year because of our uncertainties due to the pandemic, and hopefully next year onwards we'll get back to our physical conferences. We have two halls. There is a hall A and a hall B. You are presently viewing the hall B meeting. In the hall A, we have got lumbar discectomies via tube approaches, etc., and cervical tube discectomies. In hall B, we are going to talk about endoscopic decompressions solely. This similarly, we will be continuing as into hall A and hall B tomorrow morning as well. On 20th and 21st of November, we have our main conference where we'll be having very good discussions, didactic lectures, debates, etc. Now, in today's meeting, in keeping with the endoscopy theme of the hall, we are going to start off with instrumentations, knowing your instrumentations in endoscopic spine. For this, I want to invite Dr. Priyank Patel, who's a very good upcoming spine surgeon in Mumbai and an active member of Bombay Spine Society, as well as Dr. Ayush Sharma, who is also our dynamic spine surgeon here in Bombay, to take over this session, and they will be explaining the intricacies of the instrumentations and how you can understand it and how to choose your instrumentation when you want to start off with endoscopy. So over to you, Priyank.
Hi everyone, welcome to Bombay Operative Spine course, which is a part of the BSS annual event, that is the BSSCON. And today kickstarting this exciting session on endoscopy, which is going to have different masters showing in their techniques and the different surgical styles for performing spine surgery through an endoscopic route. Now, whenever we talk about endoscopy, one thing should be clear is everybody should know what endoscopy really is, because there's so much of misnomer that people just play with words. Endoscopy, when we talk about, we are talking about a full endoscopic spine surgery, which means basically with the help of a scope and magnification, you're doing everything that you want to do through a very, very small incision. And whenever you talk about a full endoscopic spine surgery, before even taking the first step of planning a surgery, what you need to have is you need to have a big armamentarium with you so that you can perform this surgery with ease. So here I'm going to tell you what all we have with us in order to perform those basic endoscopic spine surgeries. And once you realize that you have a good knack for it and you've got a good hand for it, you can of course keep updating your instrument. But here is what you require to do a very basic endoscopic spine surgery in the lumbar spine. Now, everything starts off by understanding what endoscopic spine surgery is. So there are two basic types of endoscopic spine surgery. One is a transforaminal endoscopic surgery and the other one is an interlaminar endoscopic surgery. So in a transforaminal endoscopic surgery, what you're doing is you're going from a very lateral approach and approaching the spine through the foramen. It could then be a inside out technique or an outside in technique, but all of this broadly comes into the transforaminal endoscopic techniques. The other type of techniques are the interlaminar endoscopic techniques, where we achieve the results via an interlaminar approach. Of course, I'm not going to talk a lot about these approach because in the very few hours you're going to learn these approaches in details from the master. But in order to do these, the basic instruments that we need is what I'm going to talk to you about. So whenever you want an endoscopic set, these are the things that you're looking at. So let's start with the familiar one, which we are always familiar with, and that is the interlaminar set. Every endoscopic surgery starts off with a needle, and over the needle, you put in a guide wire. Once you have put in a guide wire, over the guide wire, you have these dilators which you put in. Now, these dilators are pointy from the top, but they are not very sharp. So the chances of it damaging something, unless you are very reckless, is minimal. Once you have put the dilator, over this, you put your working sleeve. Now, this is how your working sleeve looks like. Working sleeve has a bevel in the end, and this bevel can be different designs. So you could have a flat one, you could have a one with a elongated lip, you could have one with bilateral bevels. So that is how your sleeve looks like. Now, over this sleeve goes a adapter. Now, these adapters are attached to your endoscopic instrument, and the way you attach it, you will realize where your sleeve is. So in this, I know where this end is. That is exactly where my bevel is. So this gives you a rough idea which end your bevel is. Of course, the masters are going to tell you where and how you have to keep the bevel, but that's how your instrument is. In this goes your scope. Now, this is how your scope looks like. You could have a simple scope, or you could have a scope with a working channel. So this scope that we have is a scope where you have a working channel inside. You have got a channel for your irrigation, and you have got a light source also. So that is how your scope is going to look like. Now what happens is this scope goes into your sleeve, and through that you can pass in your instruments to do your endoscopic surgery. So this is how it goes. Now, what I just showed you is something that we use for an interlaminar approach. Now, what happens in an interlaminar approach? The patient is positioned like this, and you put in your instruments through here. So, generally, the instruments that you're putting should be short length, not long instruments, right? So, that is why all the instruments or the sleeves that you have and even the scope that you have for an interlaminar approach are going to be classically shorter length. Okay, so in a transforaminal approach, what happens is we put in the instrument laterally. So you need to have a longer working sleeve so that your instruments reach the spine safely. And hence, if suppose I am using this same endoscope or if I'm using the same endoscopic technique, but instead of interlaminar, I want to do a transforaminal, the difference is going to be that the sleeve for the transforaminal approach is going to be longer as compared to the shorter length for the interlaminar sleeves. Now, once you have your sleeves already, once you have your scope docked and in place, then you have to start with your surgery. And in order to do the surgery, you have got different instruments which are available. So you start off with something called as a cutter. Now cutter is, it looks like this. And it basically is used to cut off the ligamentum flavum to get access to the inner structures. These cutters go in through the sleeves and once through the scope, and once it goes there, you can use this. Again, these are of different diameters and different lengths to suit the different anatomy of the body. Now, once you have your cutter in place, then you have something called as a grabber. A grabber looks very similar. To a disc forces or a pituitary rongeur that you have. And the classical idea for this is to grab the ligamentum flavum, to pull it and see if to differentiate between scar tissues, ligamentum flavum, and the dura, or to grab a disc fragment. So that is how your grabbers look. When you have your cutters and grabbers, you have them at different angles as well. So you could have a straight cutter like this, or you could have an angled cutter which is like this. All right. Once you have that, then in certain cases you have rongeurs also available, which have a stronger bite force, and that can be used to remove the ligamentum flavum from the interlaminar space. So once you have gone through the interlaminar approach and you have bitten off a part of your ligamentum flavum, then to cut off the ligamentum flavum, you can use these type of rongeurs, which are bigger, bulkier, and have a stronger bite. Now, one of the most important instrument that you need when you are doing your surgery is you want to get that tactile feedback from inside to differentiate between the disc and to find the annular rent, or to see if you have completely pierced the ligamentum flavum or not. And there you have this dura dissector which is there, which is basically like a guide wire, but it is blunt from the top and it's got a flat end. So this you can use to retract the dura, to dissect out the scar tissues, and in so many other approaches. Now, the set that I have shown you here is a mix between the one that we use for a transforaminal set and the one that we use for the interlaminar set. So let's say if someone wants to get only one, start off with something, then we recommend you to buy the transforaminal set, because a transforaminal set can always be used for an interlaminar surgery. But if you just get an interlaminar instrument, then it becomes a little difficult for the transforaminal approach, because then the length of the instruments are, then you don't have enough length of the sleeve to do these surgeries safely. Now, sometimes what happens, especially in a transforaminal approach, is you want to rigidly dock the sleeve on the bone. So let's say you have put in the sleeve and you want to dock it at the disc. What you can then use is a punch sleeve. So you can use a punch sleeve which goes on top of this, and you can hammer this and this will go and rigidly dock on the disc space. So this is basically the bare minimum instruments that you need in order to perform an endoscopic surgery. Now, a lot of times what happens is we just get excited and buy this. But one biggest deterrent when you are doing an endoscopic surgery is the bleeding. And to control the bleeding, you require a very important instrument which is called a radiofrequency probe. Now, these radiofrequency probes are very similar to the ones that arthroscopic surgeons and all use. The difference is the type of the probe and the energy that flows through it. So, for the endoscopic surgeries, the amount of radio frequency charge that is needed is around 4 megahertz, whereas the ones that are used in that is used for arthroscopy is 10 times lesser. What it really means is, if it is a more powerful probe, then you would have focused, high concentrated energy, and the collateral damage is going to be less. Now, when you are doing an endoscopic surgery, you have hardly this, you have a very tight space between the dura and the lateral edge and the medial edge of your facet, and you have your epidural space over there. So if you have a good, correct probe, then it is very useful to control your bleeding. And if you are able to control your bleeding well, then what happens is that the surgical time literally comes down by 50%. So of course there are desi jugards which people are using, where they are connecting the RF probe to a regular cautery machine, or they are using the arthroscopy RF probes. But if you want to do good endoscopic surgeries and you want to cut down your surgical time and cut down your learning curve, not get frustrated with the bleeding, then you need to use the correct RF probe along with the correct machine that comes along with this. So having said this, we will move on to the main event, where we have the masters telling us and showing us how to do different types of endoscopic surgeries. What are the pros, what are the cons, what are the contraindications, and where you have to be careful. Thank you.
Thank you, Priyank. That was a overview of the armamentarium one should have even before starting endoscopy surgery. So you need to have basic things before you go into it, and it's quite a bit of investment. And Priyank gave us a good overview of what all essentially is needed. We have some of our panelists here, Dr. Sandeep Sonavne, Dr. Ajay Krishnan, and even Dr. Lokhande. I like you all to join in and give your perspective when it comes to the armamentarium of endoscopy, because we all use different companies and we all use different instruments, and they all have their own advantages and disadvantages. So Dr. Sandeep, you are there?
Yeah, I'm there, Ayush, but I would actually be on the side of asking questions rather than answering ones.
Because I think Dr. Krishnan is there, and I think Dr. Lokhande is also there. Can we have everyone? So let them join till that.
Right.
Till that you can start the discussion, and
yeah.
I will be more than happy to.
We have recently started endoscopy since the last 1 year or so, and I have a couple of questions to the experts who are over here. One thing which Dr. Priyank rightly said was that the type of instruments that we should get, because once we ask the company guys, we get a whole catalog and we all confused as to what sort of instruments should we choose for these particular cases. So I think the simple instruments Dr. Priyank has very well explained. The cases to begin with are the disc cases. I personally found that the transforaminal access is much easier than the interlaminar access for beginners. And again, there are certain questions in my mind. I have the same instruments which Dr. Priyank explained, and I do the interlaminar through the same transforaminal approach. So for the basic things, I think a cutter, a rounger, a probe, a disc punch, and the whatever instruments, the RF probe, and in addition to the desi jugards that we all make, is very, very important to begin these cases.
So can I just interrupt here and ask you experts couple of questions? Now as a beginner, if I'm going to go and buy, in the market there are so many companies. You've got imported, you've got Indian ones, and practically it's a big expense. So for someone who's going to start, is it absolutely mandatory that you need to stick to one single company, buy their set, or can we do a mix and match or different things? Combination of Indian imported. What would you all recommend as far as starting off is concerned?
I think a good scope is a must, because you need a very, very good visual field. So that is, I think, the most important thing, because it is sort of a one-time buy. So I will advise you, first of all, invest in a good scope which gives you a clear vision, because this is a TV guided surgery, in the sense you will be looking at a visual image and doing your surgery. So you need to have a very good quality image to do a safe surgery. So I will recommend that you spend a decent amount of your budget on the scopes. When it comes to instrument, buying the Indian makes or the Chinese makes, it does lower your budget, but again the problem is they're very, very easy to break. So you have to choose how much your investment is. I think if you have to, if you're working with a limited investment, I think at least buy a good scope. Maybe it doesn't matter from which company you buy. I will say any German scope is very good. Either it doesn't matter which company you are taking, because they give you a very good image quality. Most of us will have a orthoscopy system in our hospital, so you can cut down the cost of that by just attaching it to your present system. That is one way to cut down the cost. When it comes to instrumentation, now there could be argument that the problem with Indian instrument is there, and everything has an advantage, disadvantage. The advantage of Indian instruments is they are pretty cheap. The problem is they're very easy to break, because even the imported one, they do break, because you're working with a very long lever arm, and the moment you do bit here and there manipulation, it does break. So that is where it is. But you can decide how it suits you. But I think you should absolutely free to buy from any company you want. I think I believe that you should invest in a good scope. You should have RF Pro, because that sort of very easy bit makes your life easy. Maybe one thing Priyank missed out is a high speed burr. Now it can come bit later in armamentarium, but you need the burr, because this you if you are doing a bit of interlaminar work, and even sometimes for transformal work, the burr really comes handy. So because rongers, you cannot these rongers are, because of the length, they are not very strong until unless using a very wide interlaminar scope. So most of the 3 mm and 2 mm rongers are not that strong, then that they will take a deep bite in your lamina. So you need to first thin them out and then take the bite. So again, burr also is a important tool, but it can come slightly later if you're only planning to do the discal work. But so you need to really I will suggest it has to be individualized. So we started with what we thought was our priority, and we started with maybe some limited things, and as we went ahead and then we started more things, we kept adding to the armamentarium. That is one way to go. And if you have the budget, then maybe you can buy everything together, but you can mix and match, and you can go ahead uh, uh, depending upon your budget. Any other panelists would like to add anything to that?
So Pramod, welcome along with
Yeah.
Dr. Arun Banot. So
Yeah.
we have the experts over here now. And Pramod, what is your recommendation for a basic instrument set to begin with?
Yeah, first of all, I think you don't need a lot of things when you starting endoscopy. And although there are numerous scopes available, we have a interlaminar scope, we have a transforaminal scope, or we have a cervical scope and a stenosis scope. But all these things are not needed for a newcomer, even for an intermediate surgeon. So I would recommend you just buy a transforaminal scope. The difference between a transforaminal scope and an interlaminar scope is just a difference in length of around 2.5 inches, not more than that. So you can use a transforaminal scope even for the interlaminar technique. All you have to do is stand on a piece of a elevated platform, so that your height increases and the table goes down. So you don't have to worry too much about getting the things done. So start with a transforaminal endoscope. Just buy basic instruments, a working channel, extension sleeve, the obturator, needle guide wires, a dura dissector. You can buy a annular cutter, which is 2.5 millimeter in size, a couple of forceps, 3 millimeter forceps, 4 millimeter forceps. And I think you don't even have to start with a burr immediately, because initially it's better for a beginner to select cases where you are not doing much of a bone work. It's better for you to just start transformal surgeries, do basic L5S1 interlaminar work, or interlaminar cases where the interlaminar space is very wide, where you don't have to drill the medial part of the facet. So you start, get experience, get the feel of the instruments, and then as you go on continuing, you can gradually add instruments every month or maybe once in 6 months. I usually made a habit of buying an instrument, new instrument, maybe once in a month, or once in a 6 months, or a year. So my drill was bought in 1 year, my carries and punches were bought in another year. So these are added instruments which are not absolute necessities, but you can always have them. It's good to have them in your armamentary. And this is how you do it, because all of us know that the cost of these instruments are very high, and it's very difficult for a beginner, especially a surgeon, to buy it for himself. If the hospital purchases it for you, then it's okay. But for usually freelancers or surgeons who own their own instruments, it's difficult. And another thing is that not many people they're not sure about whether they are going to continue with the technique. So there is no point in purchasing the entire set and keeping it after, stop using it after a few months, or couple of years. So it's basically buy the basic instrument set, get a feel of the surgeries, see that you have started liking it, see that you have developed the basic competency of using those instruments, and then you can gradually or add on the instruments later on.
So one more thing I wanted to ask was that one is the camera requirement. So Pramod, I want you to take this question. Which camera, because that is a very important part of visualization. That is one.
Yes.
And the second, which I faced personally, was the pressure of the fluid, because it's a fluid guided surgery, So I want Dr. Arun Bano to address it as to what is the amount of, or the type of pressure. How do you get the actual pressure which is enough for you to get a good visualization inside? So Pramod, you can answer the first one.
Regarding the camera, I think we personally prefer a 3-chip camera, because I think it gives a good differentiation between the various tissue structures, like what is the PLL, what are the posterior annular fibers, the neural structures, and the epidural vessels and all those things. So a 3-chip is always better. But being at a confined space, it's not like laparoscopy where it's a very big space and it's mandatory for you to start with a 3-chip camera. You can get away. All my initial days, we did endoscopic surgeries with a single chip camera. So it worked very well for us. And the optics are quite good. So the optics of all the new scopes, they are very good. So I don't think it makes much of a difference. But 3-chip is better anyway.
Okay, do we have Dr. Arun Banat over here? Banat sir?
Arun is probably not there. Maybe I can take his question.
Yeah, you can.
Yeah. So regarding the fluid pressure, again, I think, I usually use a Revo endoscope, and the make of the endoscope is round, and the working channel the endoscope is oval in shape, and the working channel is round. So there is a little bit of space, between the endoscope and the working channel. So if you see the amount of fluid which flows in through the irrigation channel of the endoscope, that is 5 times less as compared to the outflow which is happening through the space between the working channel and the endoscope. So there is no point anywhere in the surgery where, unless you block the outlet completely by using a sort of a rubber this thing seal or something like that, or use a thumb, unless you block the outlet, there is no point of any point where the pressure is going to build up significantly inside. So a lot of times, I've seen a lot of foreign faculties, they're using these irrigation flow machines, the irrigation flow machines which they use for arthroscopy. I have seen them put using a pressure of almost 100 mm of Hg, and that also for big cases like thoracic spine. So it is quite safe because the outflow is quite fast, and the fluid doesn't stay there and doesn't create a lot of pressure inside. But personally, for us to decrease the inventory, decrease the armamentary, it's better we use a gravity assisted fluid channel. Just hang the normal saline bottles on a tall IV stand and let the gravity do its work, and it's quite it's good enough. I think it's very good and very safe also. So we use it even for big cases like cervical spines and tumors and infections also. So I think that works very well for us.
Are you sure take on this?
So I think I agree with him. I think gravity assisted is what you start with, and I don't think it matters. that really that pressure is a issue. Maybe in cervical you should be slightly careful. I think that's where it matters a bit. And what we are using is orthoscopy system. They have the system, and we just took it. Instead of buying it, we are using it at 45 millimeter of mercury, and once in a while we'll increase if we really feel there is a bleeding or something. And it also works very well. We didn't buy a specific endoscopy irrigation system. We just use our from the orthopedic department, the orthoscopy system, and it works. And if you see, even gynae people also have sometimes. So if you're working in a hospital, you can sort of either, if you want to, you can just borrow it from your colleagues. And most of the time, like if your OT days are separate the way we have, we don't have a problem. So we don't have our own. We are just using the orthoscopy system, and it works absolutely fine with us. There is no issues with that. So there are ways to just decrease the cost of the armamentarium. And as Dr. Lokande rightly said, as you go ahead, you start building it. It is good to have all the options available if you're doing it every day. And but you start with a basic system and keep adding to it one by one, and keep adding. What I feel is, again, endoscopy is a very, very specific surgeon driven technique. There are some things which you like, and other surgeon might not like. So you just try it and use it. And now even the companies are giving you custom made instruments. So there are a lot of, almost like plethora of things to choose from. Start with the basic, and as you go, as your technique develops, you just keep adding whatever makes your life easy, whatever makes your surgery safe.
So one of the things which I as a beginner faced was that, because provided your pressure is good, half of the hemostasis is taken care of. That is what I believe. So one of the things that initial cases we had issue was that it used to be a lot of bleeding if the pressure was not good. And we tried to use the BP cuff around the saline bottle, which sort of worked at that time. So any particular experience regarding this, Pramod or Dr. Arun? Because we are not in a position to buy all those machines or shoulder pumps or whatever to maintain that pressure. So Dr. Arun Banot is over here, sir. Welcome. And would you like to take that question?
So just to add on to what Pramod said about the buying of advanced instruments like the burr, etc., or the cutting instruments, the beginner sometimes tends to catch fancy of using everything. The problem is they may be able to get away, but the chance for them to damage their own scope is so high, because the depth perception, the instrument control with the working channel endoscope comes over a period of time. So it is in their interest not to use the sharp cutting instruments which can damage their own visualizing equipment, which is the endoscope, which is the most expensive of all. Now coming to the irrigation part. So irrigation, most of us are still used to using the gravity assisted method, and it has worked well for several decades. As Pramod said, the fluid pressure usually does not cause much problem unless it is used over a sustained period of time. So I personally have never used a irrigation pump, and it works well even in cervical spine. We just use the height of the irrigation depending upon the need, and exactly as you just said, that you can always use a BP cuff to add on transient increase if there is a bleeder you are not able to visualize. Another important thing is there is a tendency to start grabbing the tissue and removing it quickly. So I have realized that it is better to get a hemostasis first, and then you start removing the muscle, etc., because that is what bleeds most.
Okay.
Yeah, I totally agree with Arun, Sandeep, that what your question was like, there is a lot of bleeding and it's not controlled. So you try to increase the pressure. So that's not how we work here. Here, usually before removing even the muscle or the tissues, we always use the trigger flex RF probe to coagulate. And the purpose is not just to, coagulate and cause hemostasis. Basically, it defines the anatomy properly. Unless you are defining the anatomy properly, unless you're able to distinguish between the different structures, you should not proceed, because if you by mistake you land up in the wrong kind of area, maybe you directly land up in the epidural space and you try to grab some epidural bleeders, then the bleeding is going to be so much that you're not going to be able to see anything in between. So you have to proceed with your surgery in a very stepwise manner, identify each and every structure, try to label it properly, and then you try to cut it. And after every cutting, use an RF to spread up the dissection and again delineate the structures. So that is how you proceed. You just don't be very hasty with the instruments, because if the bleeding, it's a very small area, and little bit of bleeding also completely obscures the vision. So all you have to do is just stop this procedure, just put in the remove the endoscope, put in the obturate, and wait for some time till the blood clots, and again you have to go inside. So take it in a very stepwise manner.
Ayush, you have any questions to ask?
Yeah, just to add to like, I'll also like to know what do you think of the Indian instrument system? And like, do you think, because it comes pretty cheap compared to if you guys are using the imported ones, but how do you judge them? Do you think like for a beginner it is fine to start with the Indian system, or you think it is
Yeah,
because we
actually,
know that
yeah.
what do you what like, so your opinion on this?
Yeah, actually, we have tried everything. And ultimately, I'll tell you, go for the best, buy the best instruments, because we get Indian instrument maybe for 20,000 or 25,000 rupees for one particular forceps. But the problem with these instruments, they need to be very, very precise. These are all long and very thin instruments, where the grabbing capacity of the jaw, if it is not adequate, and you see a big disc fragment in front of you and you're not able to grab it because the force of grab is not adequate, then in that case that forceps is not going to work. Secondly, the breakage of instruments of cheaper quality, they are much more. So if you use a expensive forceps which may be costing around 80,000 rupees, that may last you for maybe a few years. But if you use a cheaper one of 30 or 25 or 30,000 rupees, maybe it breaks after every 3-4 months, and again you have to repeatedly buy it. So ultimately the cost comes to the same. So I suggest, whatever delicate instruments are there, especially the 3 mm and 3 mm forceps, the cutters, these at least have to be, of a good quality company. Maybe you can buy a 4 mm forceps of a local company or local Indian company. But personally, I feel that all sharp, precise, and delicate instruments, if you get it from a good company, they are going to help you not only ease your surgery, but they are also going to be long lasting.
Yeah, I think that is the way to go, because they like, it's a one time investment, and if you can do it, I think it's worth it. Other thing, regarding RF probe, they're supposed to be used once, but how do you manage it? Do you like, the recommendation from the companies use for one case, but practically we all use more than once. So how, like, do you feel that ETU or just what
Yes.
sterilizing is it safe enough? Do you feel it increases your chance,
Yes,
because
exactly.
it's a recurrent cost? Each RF probe has a cost, so
See,
anything on this?
nobody uses RF probe for once, even in the Western European countries or even in the Asian countries like South Korea, where everything is insured. They use it for multiple times. So we definitely use it for more times, and it is the way you handle the probe. Now, many times don't even have an RF machine. I use a regular cautery machine to use it. And if you keep the power of the cauterization or the bipolar level, maybe I usually keep it to 20 or 25, and you have to use it intermittently. You don't have to just keep on pressing, because if you use a long press for a long time, obviously the fiber is going to get damaged inside. So use it in interrupted mode, use it wherever it is necessary, and don't try to do everything with a bipolar. Otherwise, don't try to make char the tissues inside. So all these things, they try to increase the life span of that particular this thing instrument. Now, To be frank, I've used a single RF probe for more than 25 cases, so it can be that long lasting. So you need not worry about the cost anymore.
I had a question for Dr. Bhanot. So there have been some instances, some reports of patients getting convulsions during the
Yes.
surgery. How do you think we can prevent that? Is there something to do with the irrigation and water pressure?
So it has been postulated to cause increased epidural pressure over a long period of time that led to seizure immediately as well as in the post-operative period or perioperative period. And as of now, this has been identified as the only culprit. So that's why the usage of pump is always not so encouraged by many centers. And a gravity-assisted irrigation, as it is already sufficient, it reduces the cost and it also precludes the possibility of such an event. That is why we do not push for the irrigation pumps. So a gravity assisted irrigation is very much sufficient and is hardly any possibility that it can cause these kind of complications. Yes, even with this, you can, if the surgery gets prolonged over, let's say 2 to 3 hours period, you're doing a stenosis or there is some problem intraoperatively, then that can happen. So either you can abandon it rather than instead of pushing for it. And many time patients will say that they have some neck pain, even when you are doing the lumbar surgery. So that is one sign you can look for during the surgery if you're doing it under local.
One more thing I would like to add is like most of these reports of having convulsions, they are almost around, from the last decade. There haven't been recent reports where, these cases of convulsions have been noted for a couple of reasons. First of all, the make of the endoscope has significantly changed. And they have the manufacturers, they have identified this issue and they have found out that it's not wise to block the outflow just to increase the fluid pressure inside. The older endoscopes, they used to completely block the outflow of the fluid so that the pressure inside built up. So that pressure was not measurable at all, and that created problems like this. So what the recent studies or the manufacturers, they have modified, the outflow is continuously it is much more, it is 5 times more as compared to that of the inflow. So unless you block the outflow completely, there is no chance that you are going to get these kind of problems. And if you see most of our techniques, that we have stopped using those rubber caps on top of the endoscope through which the instrument goes. Those were the problems initially. So we have stopped using that, and it also decreases the inventory, and secondly, it makes the surgery more safe. So I don't think this problem of convulsions or similar problems are there anymore in
So
recent literature.
Pramod, just an
Yeah.
extension to this question. I mean, sometimes,
Yeah.
when is the time when you can actually stop the outflow? I mean, there are certain times where the bleeding is more, or the flow is less. Do you stop the outflow
You
so
are
that you
not
get a steady
supposed
bleed?
to do it. Yeah, even if you do it, no, you just use your thumb to just visualize it, and it may be not more than 10 seconds, maybe 5 seconds or so. You just block it with the thumb little bit, just release it, block it, release it. And secondly, if the bleeding is torrential, I feel that you just stop doing the surgery, just remove the endoscope, put in an obturator inside. It is like, using a patty and a gel foam during open surgery. The obturator works in a similar fashion. You just pack up inside and just wait for some time, and maybe after 5 or 7 minutes or even 10 minutes, you just remove the obturator and everything, the bleeding has stopped. Just remove the blood clot and you again start seeing the the endoscopic vision properly. So I think not a issue anymore. Yeah.
One more thing is the bleeding inside the endoscope is usually not that torrential. It is usually a small bleeding, which is in a hidden zone. But because your field of vision is so limited, a small bleeder, it looks like a big one. So here the pressure of the obturator is very, very sufficient to stop that bleeding over a period of time. And as Pramod said, you use your thumb only to visualize the source of the bleeding. And if you see that this is coming from 2 o'clock, 6 o'clock, whatever area, there, then you can, once you identify, then you can use your bipolar RF probe to coagulate that bleeder, and that is when you stop the bleed, the outflow for a few seconds only. Exactly the same way.
So I'll take the last question before we end this session. Is there any difference between Indian and imported scopes and sleeves in terms of the degree of bevel, degree of angulation, etc., which actually gives you an advantage during surgery? Or do you think they're same?
Frankly, I think all the scopes, they are made in Germany. Nobody manufactures, locally. It's not possible to make endoscopes locally. And whatever Indian companies which sell endoscopes, they are actually German unbranded scopes, which they make a deal with them and they sell it as they're putting their name on it. So that is one thing. Secondly, even the German scopes have a big range of quality. Like you have an ordinary quality and you have the best quality. Regarding the angulation of the lens or the lens angle, I mean, you have variety of angles. Just like in arthroscope, you have a 0 degree, 30 degrees, and 70 degrees arthroscope. Each of them, they have their own uses. But for us to decrease the inventory, to make the scope for universal use, I think at 25 degrees, 20 to 25 degrees angled endoscope works best. Not only you're able to look in the crevices, but also you have a straight end-on view also with that. So there is no point in getting a 30 degrees endoscope because that is not going to be much helpful for the other routine surgeries.
This question will be answered in my presentation also, that the kind of scope that you use, 25 degree, as Pramod said, has served a test of time, and it actually provides you, when you are using the scope in a lateral recess region, the area which is covered by the bone and the ligament, you still tend to get to see those pictures. More than 90 to 95% of area is visualized with a 25 degrees endoscope rather than a lesser degree of endoscope.
So fine, thank you. So Satyan, I think we can move on to the main session now.
Thank you everybody for a very good introduction to this exciting session. This was actually an idea given to us by our president, Dr. S.K. Srivastav, that he said that before we start off with the main session, he wants us to give an idea about the instrumentation of what is to be taken, what we should start off with. And, that was a very important aspect which we sometimes neglect in discussing. So thank you very much to all our faculty, and you don't go away yet because you have to do all the heavy lifting further, and we will be starting with the main operative part of this conference, where we will be discussing all the different endoscopic surgeries one after the other. So I'll be handing it over again to Dr. Sandeep Sonone and Dr. Ayush Sharma, who are very senior faculty here from Bombay Spine Society, to take over the hall and take over the session. Over to you guys.
Thank you, Satyan. So we move on to the first session for the day on video techniques in endoscopic surgery, and we believe that is the future to go. We have everything ranging from decompressions to fusions right now. So we have the stalwarts here right from across the country who are doing it all, and without wasting much time, we should move on. And I invite Dr. Ayush Sharma, who is my co-moderator, to give us an overview of endoscopic techniques for lumbar spine. So over to you, Ayush.
Yeah, my video recording is already there, so they can simply play it.
Right. So can we have Dr. Ayush's video?
Greetings from Bombay Spine Society. I'm Dr. Ayush Sharma, and I've been talking on the overview of endoscopic techniques. So, just like the mobile phones which has evolved over time, the spine surgery is evolving every day. And this is how we have evolved over a period of time from open to tubular to endoscopic surgery. So, why interlaminar? Why to start with interlaminar endoscopic technique? First of all, it is a familiar anatomy. If you have been an open surgeon or a tubular surgeon, it is the same anatomy which comes into play when you're doing a interlaminar surgery. And unlike a transformal approach, it is a much versatile approach. It does allows you to tackle a lot of pathologies. So let's see the overview of interlaminar approach. So in interlaminar approach, you use the interlaminar window, which is the natural window between the lamina to approach the disc. So just like any other pathology, once you go inside, you will see the some amount of muscle. You take out the muscle, and then you come across the ligamentum flavum. You can see the cranial caudal, which is marked here. And then just like open surgery or tubular surgery, you take out the ligamentum flavum. Here the advantage is you can really make a small phlebectomy. Literally a small amount of flavum is to be resected, and then you can dilate everything and go in. So we will do some bit more, because it is you cut towards them from median to lateral just to be on the safe, and this is mostly what you do when you are doing a tubular or a open surgery. And once you have taken out the ligamentum flavum, you get some amount of a fat pad. You remove the fat pad and you see the dura. And once you have seen the dura, you look for the nerve root. And this is exactly what you do when you're doing a open surgery or you're doing a tubular surgery. This is, we have identified the root, and then we identify the disc or whatever pathology you want to tackle. So the steps of interlaminar approach, whether you do open, where you do tubular, or you do endoscopy, is the same. Now this is an example of 20 female with a radiculopathy. You can see the diffs on the lateral side. So you approach the discectomy through the shoulder. What you do is you go, you can see this was a L4-5 disc. So we approach it to the shoulder. We took out the disc through the shoulder area, and that's the disc material which is coming out. And once you have taken out the disc material, you will check for the mobility of the root, like you do for any other open or a tubular pathology. This is just to show you how it looks like to do the interlaminar approach. So we have taken out the disc material. This is the disc material which came out, and then we will just see this is the root, mobility of the root, and you can see we have gone from the shoulder area. This is another pathology. This is more of a central disc. So here, instead of going to the shoulder, you can very well easily use the same approach. Instead of going to the shoulder, you can go to the axilla of the root. Because it's a central pathology, it is much more easy to go to the axilla of the root. And as you can see, we are going between the dura and the nerve root, and we are doing the discectomy. So the size of the scope really allows you to choose whichever way it is easier for you to tackle the pathology. So here, as you can see, the first case we went to the shoulder, which is the traditional approach, and in this case we went to the axilla and we did the discectomy. This is the end of the discectomy. You can see the root and the dura completely free. So it is a very, very convenient approach in terms of familiarity, but it does come with certain challenges. For example, if you have been an open surgeon or tubular surgeon, you use a microscope, and it is like an assisted surgery. You have an assistant who helps you do the surgery. But endoscopy is completely unassisted surgery. If you see, I'm the only one who is looking at the scope and the screen, and rest of them are just looking towards me. And the guy who is looking at the screen is simply waiting and watching. So at the end of the day, you have to do 99% of the job, and only 1% is the help you'll get with the assistance. Again, it's a very, very high mobile system, unlike a open system or tubular system, which is quite fixed. Endoscopy is a very high mobile system, and you need to control the mobility of the endoscope. It could be challenging in the initial stages. Again, epidural bleeding is a bit of concern, because if it starts bleeding, you won't be able to see anything. As you can see here, we cannot see anything. If you cannot see anything, you cannot proceed further. So you need to tackle it very judiciously, and you need the RF probes, and you need to exactly pinpoint that bleeder and locate it and coagulate it, as you can see what we did. And now we have a good vision to continue with the surgery. So again, this could be challenging when started with the interlaminar surgery. Again, the nerve root retraction. Now you don't have assisted retraction. Your assistant is not going to retract. So you will need to use some tips and trick. And as you can see, what we are doing, we're using the outer bevel just to retract the root so that we can do the job safely. So you have to learn these manipulations. So what we did is completely retracted the root, and now only thing we can see here is a disc. So then we can use a sharp instrument to remove the disc very safely, and now you can see the mobility of the root is very good at the end of the decompression. Again, it does have its limitation. Although it's very versatile, but it does come with some amount of limitation. As you can, for example, this case, a higher level disc, a central disc, the interlaminar window is very, very small. So it could be very challenging to do interlaminar approach. So what we did here, we went for a transforaminal approach here, and you can see this is the transforaminal approach. So that's what it is. So sometimes you do need other approaches to complement your interlaminar approach. Again, another case, there was a big osteophyte coming here, and we thought it is not very safe to go and do it interlaminar. So we did a transforaminal approach again. And here what we did is we navigated it with a navigation. We navigated the endoscope. We could track the osteophyte and do it through the transforaminal approach. So is it worth it? Is it worth to learn another technique, another technology? So this is a patient. He came with a foot drop, complete foot drop L4-5, and this is post surgery on the same day, walking comfortably 4 hours after surgery. So when you look at this patient, I feel it is worth it. And this is my case. You see, this was a re-surgery after a open surgery, a reprolapse. And this is the scar when we had previously operated with open surgery. And this is the scar we gave the patient for a 2-level disc prolapse. So again, this really makes you believe that it's worth pursuing the endoscopic surgery. And as they say, many people have a good aim in life, but for some reason, they never pull the trigger. So that is it. You need to try endoscopy. You need to go and learn it and see if it works for you. You never know. You could be a great endoscopic surgeon. You just need to try to pull the trigger. So thank you so much. So that is all about the overview of interlaminar endoscopic surgery. Thank you.
So, thank you, Ayush. Thank you very much. Just a very basic question to the panelist over here. There are multiple approaches to the same thing. Like we have the interlaminar system, we have the interlaminar approach, the transforaminal approach. My question to the panelist, and we start from Dr. Banot. How do you select a patient for a transforaminal interlaminar approach? Transforaminal or interlaminar approach. What is your patient selection? So Dr. Banot or Dr. Pramod can take that question. Dr. Banot, you are muted. You are muted.
Yeah.
Yeah.
So for me, any disc which is possible to be treated with the transforaminal approach, that becomes choice number 1. When the disc is migrated downward, especially, or it is high up migration, then it is preferable to use interlaminar approach. For upper lumbar herniations, again, transforaminal approach is preferable because you do not have to handle the spinal cord, especially even for the lower dorsal spine like D10, 11, 11, 12, etc. Transforaminal because you can work under the dorsal, the spinal cord, and you don't have to manipulate it at all. As far as L5, S1 level is concerned, or there is an element of lateral recess stenosis or a calcified disc along with the new disc herniation, such situations are better tackled with the interlaminar approach because you have a better choice of instruments, like you can use the endoscopic goose, chisel, osteotome, burr, etc. to cut open the osteophyte as well as remove the herniated disc. So that is how I personally make this decision.
Right. And Pramod, what is your pre-operative workup on the imaging or radiology for you to decide this particular things, provided you can do the both the approaches in a given patient?
See, the pre-operative planning is more important for a transformal approach. It is not needed so much for an interlaminar approach. So for a pre-operative planning in a transformal approach, first of all, we need to see whether the transformal approach is possible. Especially at L5S1 level. So if the disc is at L5S1 level, and if you have a very high iliac crest or a very stout transverse process, or the angle of the iliac crest is very acute, where it will be a hindrance for the passage of the instruments, then in that case it's better for us to move on to the interlaminar approach. Secondly, we look at the anatomy of the nerve root. So look at the size of the Camden's triangle. If the size of the Camden's triangle is vertically narrow, that means you have a low origin of the nerve root. Sometimes you just look at the parasagittal sections of the MRI pictures and look where the nerve root is lying at that particular level which is to be operated. And if you have an adequate space between in there, then I think it is safe for us to do a transformal approach. Because the basic difference between interlaminar and transformal approach is part of the transformal approach is done under CIAM guidance, So although, you are in a very dangerous area, precarious area around the nerve root. So that first part is totally CIAM guided, where you insert the needle, where you insert the cannula, dilator, working channel and the endoscope. Till you insert that, the endoscope is not inserted. Whereas if you compare it with the interlaminar approach, the part which is not, not dangerous or not, completely safe, that part is only CIAM guided. So what it means that for an interlaminar, you put in the dilator just on the surface of the phlegm. You're not penetrating the phlegm. So that is completely done under CIAM guidance, and it's very safe. So you don't need that much of a planning for a
Yeah, but Pramod, for our initial cases in the interlaminar approach, I mean, we thought on the similar lines that we just dock the scope into the lamina and that's it. But we had certain difficulties in the sense that sometimes the interlaminar window might not be very big. And the second thing is that if the medial facet is overhanging, then probably you might have to burr it a bit. So your take on that regarding the pre-operative planning? We personally believe in taking an X-ray in all cases of an interlaminar approach. A good quality X-ray which shows us the interlaminar window.
Yeah, the X-ray is definitely important, but also you can get a fair amount of idea just looking at the axial MRI sections. See where the disc and see whether the nerve root is hidden under the facet. So basically, you differentiate the interlaminar approach in two ways. Either you have a narrow interlaminar window or a very wide interlaminar window. And secondly, depending on your experience, like whether you are a novice beginner or whether you are intermediate or an advanced endoscopic surgeon. So for a novice people, I wouldn't suggest to start with a case where there is a narrow interlaminar window where we have to do a lot of bone work, because handling of the drill, handling of the endoscope, all these things, it takes time. All these, the basic of learning or training in endoscopy is not only you have to learn the handling of the endoscope, but you also have to learn the handling of the instruments which are going through the endoscope. So there are multiple things you're controlling, and in an interlaminar endos as compared in an interlaminar approach as compared to a transformal approach, the working cannula is not anchored in the disc. So everything is floating, you have to stabilize everything. You have to stabilize the working channel. You have to stabilize the endoscope, because if you leave the endoscope, it will drop inside. It will just fall down with gravity. And secondly, you have to, use the instruments also. So, you have to juggle three things at one time. So it takes time. So I always prefer novices to start with a case with a narrow, wide interlaminar space. Look at the axial sections where the nerve root is hidden. Look at the relation of the nerve root with the disc space. If the nerve root is hidden under the facet joint or it is covered significantly by the facet joint, that is not a case for a beginner. I think it's a case for an intermediate endoscopic surgeon.
Okay. Thank you, Pramod. I think we will discuss more of this after watching Dr. Banot's video. So maybe have Dr. Arun Banot show us the surgical techniques, the tips and tricks, and then we can have further discussion on this particular topic.
Good evening. My name is Arun Bhanot, and today I'll be speaking on full endoscopic interlaminar spine surgery technique and its video demonstration. Goals of a surgical technique for spine are to address the pathology, and when we talk in reference to spine, that usually means that we have to remove an offending compressive structure that causes pressure on the neural elements. While doing so, we aim to preserve the stability and mobility of the spine as much as possible. And in addition, we should always strive to preserve the normal structures that happen to simply lie in our way to access the pathological lesion. When we compare the conventional open or microscopic, or for that matter even tube assisted surgeries, the essential steps are that we have to cut the skin, subcutaneous tissue, erase the paraspinal muscle. Sometimes we have to do laminotomy or even laminectomy, and then we excise the ligamentum flavum to have a wide access and a safe and better access to the pathological lesion. Then we retract the neural tissue. So in this process, we happen to cut a lot of these structures which are simply standing in our way, and they are just like an innocent bystanders, and they get damaged or cut while accessing the pathological lesion situated deep in the spine. But in the full endoscopic surgery, where the incision starts at the skin and the working instruments go directly from the skin up to the ligamentum flavum, and we do not need to cut the whole of the ligamentum flavum, just create a small hole. Thus, full endoscopic surgery causes least of the collateral damage to other normal structures that happen to lie in our way. What does full endoscopic spine surgery mean? It means that you do everything through a small working channel endoscope. There is no need for any extra portal like in triangulation for other arthroscopic techniques. The instruments go in a coaxial manner through the working channel of the endoscope itself to do work on the anatomical structures deep inside the spine. The full endoscopic technique provides excellent optics of anatomical structures as they naturally exist in our body, and the reason for that is the use of saline as a medium of vision. The full endoscopic spine surgeries are usually done under constant saline irrigation. Thus, the flow of the saline keeps washing the small debris and small bleeding points to provide clear visualization of the anatomical structures in a manner that they normally exist within the spinal canal. Now, the full endoscopic spine surgery was initially widely used through a transforaminal approach, but over a period of time, it was learned that the transforaminal approach had certain limitations. Now, some of those limitations are specifically in reference to down migrated herniations when the hypertrophied ascending facet or the upper edge of the inferior pedicle along with lateral edge of the ligamentum flavum could act as hindrances for safe and successful access to remove the down migrated herniation. Similarly, for up migrated herniations, the foraminal ligaments and the lateral edge of the ligamentum flavum can obstruct a clear visualization to remove the up migrated fragments. Though up migrated fragments are relatively easier to remove as compared to down migrated ones. In addition, if you look at the foraminal size and location, so we know that in as compared to upper lumbar spine, the lower lumbar foramens, especially the L4-5 and L5-S1, where most of the herniations happen, the vertical dimensions are gradually going smaller, and as there is disc degeneration, allowing disc to settle in, the disc height decreases. Thus, it can cause foraminal stenosis. And though it may not completely rule out the use of transforaminal approach, but it may certainly make its application more complex and difficult in a narrow foraminal height. Similarly, for L5S1 levels, We know that many of the L5S1 discs are situated deep in the pelvis with high iliac crest, and sometimes the transverse processes are also big, thus reducing the small area through which the transforaminal access can be done. And when it is combined with the task of removing an upward migrated herniation at L5S1, transforaminal approach becomes all the more difficult. So, to circumvent these problems through the transforaminal approach, the full endoscopic technique has been applied through the interlaminar approach as well. And application of the interlaminar full endoscopic technique has opened a lot of new avenues to treat various spinal pathologies. Now, when we compare the transforaminal versus interlaminar full endoscopy, in transforaminal, the working cannula is essentially fixed within the confines of the intervertebral foramen and there is hardly any mobility. But in the interlaminar approach, as you can see here, the cannula is freely mobile. One can tilt it up and down, left and right to have a wider inspection of the operative field, and the endoscope can also be advanced further anteriorly and one can look under the nerve root as well as around it for a better inspection and execution of the surgical steps. Another difference is of optics. So when we compare the microscopic versus endoscopy, the visualizing optics in microscopic technique are quite far from the anatomical structures that are being worked upon. There's a few inches to few feet, whereas in the endoscopic picture, the optics are very close to the structures being worked upon. Now, if you see the picture below, the microscopic picture shows down a tubular vision, and if we have to access these recessed areas in the spinal canal, we have to essentially cut open this overhanging structure. That means that we have to do a wider bone excision to access the difficult to reach areas within the spinal canal. But when we apply the endoscope, which goes very close to the anatomical structures in the middle picture, we can see that it provides much better lateral coverage of the area that can be visualized, though it may not be easy to work on, but at least you can inspect. But when you use a angled endoscope as compared to the 0-degree endoscope in this picture, especially the one which we use, which is a 25-degree angled endoscope, one can see that your visualization is far superior and you can see almost more than 90 to 95% of the area inside the recessed region as well. And with the floating cannula, one can tilt the cannula to even operate under those areas without needing to essentially remove the overhanging structures. Now, the interlaminar full endoscopic technique is done through a small 8 millimeter working tube. Thus, you can just use a small 8 millimeter incision, stab incision, and then you can introduce your instruments. The patient is positioned prone. The interlaminar technique is usually done under general anesthesia. Some people may do it under epidural as well. Now, after positioning, the first step is to plan the target of your obturator insertion. So that in the lateral view, the target of the obturator is the inferior edge of the superior lamina of the segment shown here. In the AP view, you target the lamina facet junction where it is crossing the disc space as shown here in this blue dot. So this is where we initially tend to target the tip of the blunt obturator to touch. Once the obturator is docked onto the desired target, then the beveled working tube is slid over the blunt obturator, and once the working cannula is positioned properly, the obturator is withdrawn, and this is how the cannula looks like. So this is a reasonably good position for the beveled working tube positioned over the L5S1 interlaminar space. Small surgical videos showing these steps one by one. The obturator is introduced into the spine under lateral fluoroscopic guidance, preferably, so that there is no inadvertent anterior advancement of the blunt obturator. Once the obturator is docked onto the desired bony landmark, then the beveled working cannula with the bevel facing medially is slid over the blunt obturator as shown here. So the bevel is facing medially, and once the cannula is docked onto the target point, then the blunt obturator is withdrawn, and then the endoscope is brought in. Now, the endoscopic video is shown here to show how the non-dominant hand of the surgeon is used to control the position of the endoscope by keeping that little finger of the non-dominant hand resting on the fluid adapter attached to the working tube, and the thumb is supporting the endoscope. So you can see here we can advance the scope down or withdraw it depending upon what kind of vision do we need. And this is the still picture showing the same thing. Now this is a surgical video showing initial steps of the endoscope. This is a large L5S1 herniation, slightly down migrated, and it is a central to paracentral herniation on the right side. You Once you introduce the endoscope, you see this muscle and intermuscular fat tissue which is covering the interlaminar window, which is removed with the endoscopic grasper, and then you can start seeing the pale yellow color of the ligamentum flavum. The flexible bipolar is used to achieve hemostasis and shrink away any other structures. Once the ligamentum flavum is exposed, the working cannula is pressed gently downwards to keep the ligamentum flavum taut. This allows easy cutting of the layers of the ligamentum flavum. At this stage, we start cutting the ligamentum flavum layer by layer using the endoscopic scissor. Once we advance the scissor through the various layers, we can visualize that the ligamentum flavum changes its colors from pale yellow to white to pinkish as it reaches close to the epidural space. While cutting the ligamentum flavum or doing any instrument use, it is important that the tip of the instrument is always kept inside the endoscopic vision. So this is a small surgical demonstration, opening the ligamentum flavum. As we cut through, we can see that ligamentum flavum is becoming pink, and we open the ligamentum flavum. From then we extend this opening from medial to lateral till the time we can see the lateral edge of the traversing nerve root. From here onward, it is similar to our microscopic steps where we reach the lateral edge or the shoulder of the traversing nerve root, and then we retract the nerve root and do the surgery. Except that in full endoscopic interlaminar technique, we do not have to cut open through the whole the ligamentum flavum. We can simply create a small hole with the scissor as shown here, and then as we advance the beveled working tube, it allows the ligamentum flavum to dilate and permit the passage of the working tube without needing to cut the ligamentum flavum in a big manner. Now this video shows where we left off in the previous one. And then once the lateral edge of the nerve root is exposed, we retract it with the dissector and then rotate this beveled working tube in such a manner that the bevel now bevel is facing laterally and the flange of the cannula is medially, thus protecting the traversing nerve root from harm's way, and there's no need to retract the nerve by another assistant. The beauty is that this working cannula is pressing downwards rather than pushing medially onto the nerve root. Thus, there is hardly any retraction or handling of the nerve root. Once the disc is exposed, then you cut open through the annulus with the endoscopic cutter, and the fragments are mobilized and removed. And once the fragments are removed from the shoulder region, then you rotate the cannula to inspect the decompressed traversing nerve root, the thecal sac, axilla, shoulder. And as we withdraw, we can see the tiny hole in the ligamentum flavum which falls back. This is another surgical video showing similar steps but also showing the decompression through the axillary space. Now the S1 root is lateral edge is mobilized, and we turn the cannula, and then the disc is exposed, and then the annulus is being opened. The disc fragments are mobilized, and the fragment is being taken out. So it's a large fragment. Then you rotate the cannula and inspect the nerve root. In this case, it was a large central and paracentral herniation, so we inspect the axillary space as well, expose the axillary space and do the decompression through the axilla as well. So at the end, we can see a well decompressed thecal sac, axillary space as well as the shoulder region of the traversing nerve root. Now, the calcified herniations, which were earlier not considered suitable for use with the endoscopic technique, can also be treated with the help of specialized equipment. Now, this is a case of a 43 years old male doctor who is an active sports person who presented with left foot weakness and limping for a few weeks. And this was because he had a L5S1 small acute disc herniation in the lateral recess region in on the background of a chronic calcified disc hump at L5S1 level. So we chose to do an interlaminar technique in this case. And after the ligamentum flavum has been cut and the nerve root has been, lateral edge of the nerve root has been identified, we used the blunt dissector to retract the nerve root, rotate the bevel to protect the nerve root, and then first look for the soft disc fragment. This is the soft disc fragment between 7 to 9 o'clock, which is grabbed with the endoscopic forceps and taken out. And now you can see that we are touching the hard component. We are touching with this probe and the bony hump is seen. This is a end cutting face mill which is used to thin out the osteophyte calcified segment. Then this is the endoscopic osteotome used to cut open through the calcified component. And then once you remove, then you again rotate the cannula to see the adequacy and if there is any residual osteophyte which is found in this case. And the residual osteophyte can also be removed using this endoscopic Carrison punch and a repeat use of the endoscopic osteotome. Once you do the decompression, you again check the axillary space, and this is the axillary space is decompressed, the shoulder is well decompressed. So that is the end of the procedure. This is the post-operative MRI of the same patient with the calcified disc now, which is showing reasonably good adequate decompression. Now, though there is a talk on the use of the endoscopic interlaminar technique for stenosis, just for sake of completion, lateral recess stenosis. This is the case of lateral recess stenosis, L4-5 degenerative listhesis with the left lateral recess stenosis. The patient had mainly left leg radicular pain, claudicant in nature, hardly any back pain, and her dynamic X-rays did not show any undue mobility. So we chose to do a interlaminar full endoscopic decompression of the lateral recess, and this is post-operative MRI showing adequate decompression. Now, when we compare the full endoscopic technique with the earlier prevalent microscopic or other minimally invasive endoscopic procedures, these were promulgated for the benefits of small skin incision, less collateral tissue damage, good vision inside the field, better protection of the nerve tissue, and wide application to all types of indication. Now, if we test the full endoscopic technique on these parameters, let's see where do we stand. When we talk of full endoscopic procedures, instead of the small skin incision, you get the smallest skin incision. In terms of less collateral tissue damage, it provides least collateral tissue damage. In terms of good vision inside the field, it provides excellent vision inside the field, as I said earlier and showed on the videos. In terms of better protection of neural tissue, it provides the best protection of the nerve tissue because you hardly have to handle or retract the nerve tissue. Now, coming to the wide application to all types of indications, with the advent of interlaminar technique, we are getting there to use it on much wider scale in treating various spinal pathologies. Thank you for your attention.
So very comprehensive talk. Thank you for an excellent overview of interlaminar technique. So let's start the discussion, and we have almost the complete panel. We have Dr. Sujit Kumar with us. So let's call in everyone, and let's start with like this. Basically, the aim of this course was to introduce it as a basic course for the beginner, and there is a big debate when it comes to whether the interlaminar is the first a beginner should start, or should you go with the transformal. So, Dr. Banod, let's start with you only. What do you think? Is it because you are familiar with the approach? Do you think it is the easy thing to start, but you again have to tackle the mobility of the scope? Or do you feel the beginner should start with a transforaminal endoscopy first?
So intuitively, interlaminar approach looks to be attractive to start with, as you already said in your talk that it is using the most versatile approach that we use to access spine and treat it. But I have always used this sentence: the transforaminal approach is difficult to conceptualize in your mind because you have never learned it structurally in your training program. But once you get to know the concept, it goes into your mind. It is easy to execute. It is mathematical: 1, 2, 3. You hit the facet, you go under the facet, you reach the disc, you advance the cannula, and then you will work under the nerve root and remove the disc and see the nerve root. So there is hardly any scope of something going wrong if you follow the steps one by one. Execution wise, transforaminal becomes better because it is mathematical. In terms of interlaminar, understanding it is easier because you know there is a ligamentum flavum, you have to cut, you have to see the nerve root. But the problem is of handling of the scope, the depth perception, how to control the depth of the scope, how to control, because it's a floating cannula, you do not have anything to support it, and the cannula can sometimes come out. And many a time there is a small bleeding. You need to learn the fine intricacies of rotating the cannula, pressing it to control the bleeding points, etc. So this comes with practice. So both have their own advantages. We always feel that transforaminal is just too difficult to understand. The moment somebody applies the mind and understand, then it is easy to do. This one is easy to understand, but needs some time of practice of hands. You need to create a hand memory also, that you do not have to think that I have to lift the scope or I have to let it go down. That means that it can happen automatically without you consciously trying to do it.
So let's bring the other panel. Dr. Pradyuman, you are there. What do you think? Do you agree with Dr. Bhanot, or you think you have any new tips or your point of view on this? To start with, what do you think is better? Do we have? Or anyone can come in. What like it because we are discussing it. So maybe Dr. Lokhande, what do you agree that what I personally believe is it is easy to start with interlaminar, but it is a bit difficult to master because of the so many intricacies involved. But because we come with a good anatomical knowledge of interlaminar window, so it is much more easy to start.
Personally, I think the biggest challenge of learning endoscopy is the handling of the instruments, and it's a working channel endoscope. Not only the endoscope is there, you cannot move the endoscope with the instrument in a different direction and the endoscope in a different direction, just like arthroscopy. We don't do triangulation here. Okay. So we need to learn to manage the endoscope. We need to learn to manage the instrument, the rotation of the endoscope, seeing the tip of the instrument, what it is cutting, all those things need to be learned. And this is not something which is you have already learned during open surgery. It's a completely new technique or new concept of using endoscope. So when you're learning, it's like learning swimming. If you're learning to swim a front crawl or a freestyle, first they teach you how to use your hands, then how to use the feet, and try to synchronize all these things together, then you can start swimming. So similarly, I think it's easy for people to learn things effectively when you do learn things in a stepwise manner. And that thing happens with a transforaminal endoscope, because here there is no fear of the endoscope falling downwards because of gravity. Secondly, you don't have to control the working channel because it is already anchored inside the disc space. So the only thing you need to learn is to rotate the endoscope, use the instruments, understand the depth perception, use the trigger flex handle. Trigger flex handle has got two functions. The pressing function, it increases the angle of the tip so that you can coagulate at the periphery. Secondly, the rotation of the handle itself, it will help you to get to a particular area which you want to coagulate. So all these things, they need to be learned properly, and this cannot be learned properly when you're struggling to hold the endoscope and struggling to control the working channel. So I think it's easy for us to start with transformal endoscopy first.
Thank you, Pramod. Just one question. Let me get the other panelists over here. Question to you, Dr. Sukumar. We have seen your excellent work on all the groups that we are in. Just a question. Sometimes when we go through an interlaminar approach, it's not possible to exactly dock the scope through the angle that we go onto the lateral aspect of the nerve root, and we frequently tend to dock it or land up on the actually the axillary portion of the nerve root. So in that case, how do you decide or how do you take a call? What is the maneuver that you do apart from the video, excellent video which Dr. Banod showed us?
Yeah, as Dr. Lokande said earlier, it is the correlation of MRI is the key here. If you think the fragment is in the shoulder or in the axilla, based on that, you plan for landing your sheath, docking your sheath, and drilling the facet. If we have a wide interlaminar window in MRI and there is some CSF space lateral to the root, the traversing root, then there is no need to drill too much facet, or there is no need to drill. So our professor whom I got trained, Dr. Rutten from Germany, always says that you err on drilling little bit more bone while you are learning. So this always helps you, like once you expose the root, you can't drill much as a beginner. So as a beginner, try to err on drilling 1 or 2 millimeter more bone, even though it is not necessary initially. Once you are used to it, and the correlation of MRI is the key again. Once you have done the MRI correlation and you have gone in and you expose the root, it's exposed partially, and you are not able to retract the root medially as we do regularly, then there is some disc fragment which is, or hard hump, which is preventing from retracting medially. So then we need to definitely drill a little bit more for the safety. So we can use the protection bars available now in the market. So drill the more. So ideally, for any beginner, looking the lateral edge of the root is the key. You want to have a safe surgery. If you are dealing with the axillary fragment, as Dr. Arun Banod showed, safely small fragment, once we remove, the root becomes lax, then we can manipulate the root. So definitely, as a beginner, better is to go as lateral as possible initially.
Okay, let me get Dr. Ajay Krishnan over here. Dr. Ajay Krishnan, if you are around, just a question which intrigues us, or even in open surgeries, how much decompression is enough? Because this is a magnification surgery. You get a small fragment and you get that, feel fine. We've got the whole disc out. So question two, in fact, all the panelists can chip in. How do you decide what is the end point of decompression in an endoscopic nerve root decompression surgery? Dr. Ajay Krishnan, if you're on. Pramod, can you take that question?
Yeah, I think the thing is, the principle is the same like in open surgery. How do you decide the endpoint of discectomy after open surgery? Just the feel. The second thing is you need to look around, especially in migrated fragments or huge fragments.
So Pramod, let me interrupt you over here. The feel in open surgery is by retraction with a nerve root retractor, right? In this case, this probably is the missing because we are holding the scope and not any nerve root. We are not retracting the nerve root as such.
In the transformal, you mean to say?
Yes. Even in the interlaminar.
No, you can retract. You can definitely retract the nerve root in a interlaminar, because the working channel tip, the bevel tip, it works as a dural retractor, and you can move the endoscope. You can look in different directions. Actually, the vision, because of the 25 degrees angled endoscope, the vision is much better than looking from a microscope with a bird's eye view. So you are actually able to look under the dura, you are able to look under the nerve root. If you position your endoscope properly, you will be able to see the pedicle also, which is located up with a good interlaminar space. So I think vision is not a problem, and definitely it's more visual and the tactile feel which you always, which always decides how much discectomy needs to be done.
Dr. Banod?
Yeah. So, Sandeep, there are two things. One, you always try to match what you expected on your MRI. That is it sufficient to the matching of the size of the MRI, what you take out? Two, as Pramod said, you can advance your endoscope right up to the base of the vertebral body or the disc, and you can just rotate the scope and you will be able to see under the nerve root, which you cannot see with any other technique, right? Third, you have flexible probes also, which can bend under the endoscopic view, and you can use them as probes for feeling under the nerve root, just like you use your right angle hook. Now, we do not try to retract the nerve root in the early part of the surgery. We just dock the cannula, rotate the bevel to protect the nerve, do the decompression. But once you have done the decompression, now your root is freely mobile. At this point of time, a little bit of retraction and feeling with the probe, the right angle flexible probe, does not do any harm because your root is decompressed, and it allows you to get that same tactile feel that you do with your open surgeries, but in a much superior manner because you are seeing it in a better way.
Okay. One question which comes to my mind is that in one of the cases we encounter nerve root anomaly. So any experience with that? The guys who have been doing it in large numbers, like Dr. Banod, Sukumar, Dr. Lokhande, anybody of you with experience
Yes,
with
I
root
think,
anomalies?
I think this has been quite interesting experience. Not only the lumbar spine, I've got experience. I've seen cases even in the cervical spine. Actually, the incidence of nerve root anomalies which I've saw was more in the cervical spine. We have those conjoined nerve roots and everything. But as if you stick to the basic principles, like what is the principle of endoscope of microdiscectomy? You just open up the ligamentum flavum, you identify the nerve root, you look at the lateral border of the nerve root, just look beyond the lateral border of the nerve root. It is sometimes safer to palpate the medial border of the pedicle, so that ensures whether you are far lateral that much as possible, as much as possible. So these are the basic tips which prevent you to damage the nerve root by mistaking it for a herniated fragment or something like that. So I think the principles are the same like microdiscectomy, nothing new.
For the sake of time, I think we should move ahead because we have. So let's go to the next series of talks for full endoscopic interlaminar decompression for lumbar canal stenosis. And we have Dr. Pramod Lokhande, who will talk on the surgical video, and then we will discuss about it. So, Dr. Lokhande.
Yeah.
You can play the video, I think so.
Presentation. Yeah. Hello friends, my topic of discussion today is full endoscopic decompression of spinal stenosis by interlaminar approach. If you look at the evolution of minimally invasive spine surgery, the ultimate aim of any spine surgeon is to do a percutaneous procedure with minimal bone resection and soft tissue damage. Full endoscopic operations are one such procedures. They can be considered as one of the most sophisticated forms of minimally invasive spine surgery. When it comes to lumbar canal stenosis, in central and lateral recess stenosis, the main pathology lies inside the spinal canal, and therefore interlaminar approach is the best way to decompress these pathologies. Whereas in foraminal stenosis, the transforaminal approach is the only way to decompress foraminal stenosis. There are some surgeons who use a transforaminal approach to decompress lateral recess stenosis, but personally I don't agree with this approach because I always think that the decompression is going to be incomplete. There are two options of endoscopes available. The stenosis endoscope, which is a larger size endoscope with a working channel of 5.6 millimeters and a double irrigation channel. And secondly, the regular interlaminar endoscope, which is routinely used for discectomy procedures with a working channel of 4.1 millimeters in size. The advantages of stenosis endoscope is that it offers a better field of vision because of superior optics and better irrigation fluid pressure, and the larger working channel size also allows passage of bigger or larger instruments, which allows faster decompression, whereas the regular interlaminar endoscope is more useful when discectomy is the main focus of the surgery along with stenosis decompression, and this is especially true when the disc is more centrally located, which needs a lot of neural retraction. It is also better suited for decompressions at upper lumbar levels where the interlaminar space is more narrow. Another advantage of interlaminar endoscope is that because of the single irrigation channel, less irrigation fluid is required. The surgical procedure begins with patient positioning. There is a tendency by some MIS surgeon to give a kyphotic position during surgery. According to them, it opens up the interlaminar space, but it will always cause under decompression. The lordotic position is the real life position which is assumed by the patient during walking and standing, and it is in this position the symptoms are the worst. Therefore, I always prefer to give a lordotic or a neutral position during surgery. The skin entry point for over the top decompression is slightly different. If you take a standard medial entry point, even though ipsilateral decompression is easy in this case, it is very difficult to reach the contralateral nerve root unless we drill a significant part of the base of the spinous process. So that is the reason why we take a lateral entry point where along with the ipsilateral decompression, it is easy for us to decompress the contralateral nerve root. The actual surgical procedure begins with the docking of the working channel or the sleeve. For this, we have to identify the center of the interlaminar space. 8 or a 10 millimeter incision is taken. The dilator is inserted till it reaches the facet joint. The position is confirmed on C-arm. Then over the dilator, the working sleeve is passed. And once the position is confirmed, the dilator is removed. And this is the final docking of the working sleeve or the working channel. These are the photos showing the actual surgical procedure and the position of the video endoscopic trolley. Once the endoscope is inserted, some amount of muscle and adipose tissue needs to be removed to expose the ligamentum flavum and the bony margins from all the sides. Then the next step is to identify the tip of the descending facet. These are the soft tissues removed from the tip of the descending facet, and the superficial part of the ligamentum flavum is detached from the medial margin of the facet joint. Once the tip of the descending facet is identified, drilling is started with a 4 mm oval burr with a side protection. It is continued along the medial margin of the facet joint to reach the superior lamina. Drilling is always performed under very high magnification to avoid damage to underlying structures, and the tip of the instrument should always be visualized. Drilling is continued till the tip of the ascending facet is identified. This completes the superior extent of the decompression. So this is the tip of the ascending facet. Once that is visualized, drilling of the medial margin of the ascending facet is started, and it is continued downwards till you reach the middle of the pedicle. This is the drilling of the medial margin of the ascending facet. The purpose is to widen the interlaminar space so that the nerve root is uncovered. So this is how it is done. You start at the tip of the descending facet, go along the medial margin of the facet joint to reach the superior lamina. And once that drilling is completed, you start drilling the inferior lamina. Once bony decompression is complete, we start decompression of the ipsilateral side. You can see that the endoscope is vertically positioned in this case, and it begins with cutting of the ligamentum flavum layer by layer, starting from the midline and reaching towards the lateral side. And the flavum is cut in a layer by layer manner till the epidural space is opened up. We continue cutting the flavum laterally till it reaches the medial margin of the facet joint. Then the remaining thinned out lamina and the facet, medial part of the facet is removed along with the ligamentum flavum with a Carrison punch to expose the nerve root and the dural sac. This is removal of the superior part of the ligamentum flavum along with some part of lamina. Step is that of contralateral decompression. Here the endoscope is tilted over the dura under the ligamentum flavum to reach the opposite side nerve root. And this is the ligamentum flavum which is being separated. This is the hypertrophied contralateral facet joint which is being drilled to thin it out, and the thinned out hypertrophied facet is then removed with a Carrison punch to uncover the lateral border of the opposite nerve root. So that's the opposite nerve root with the axilla and the dura there. So this is a well decompressed contralateral nerve root, the dural sac, and finally the ipsilateral nerve root. The extent of decompression can be confirmed intraoperatively on using C-arm. The superior extent is the tip of the ascending facet, and the inferior extent is the middle of the inferior pedicle. This is another video of contralateral decompression from the right-sided approach of severe bony canal stenosis. So this is the hypertrophied ligamentum flavum which is being removed and drilling of the hypertrophied facet of the opposite side. This is the drilling of the medial margin of the facet joint, drilling of the inferior lamina. You can see that the side protection, it prevents direct contact of the drill with the neural structures. Then the thinned out hypertrophied facet is then removed with a Carrison punch to expose the lateral border of the nerve root. And this is the medial margin of the facet which is being resected, and there is a well decompressed nerve root of the opposite side, the lateral border well seen, and this is the dural sac, and finally the well decompressed ipsilateral nerve root. Sometimes I prefer to do an en-bloc resection of the ligamentum flavum, especially in cases with severe bony stenosis. Now this is the right-sided approach. This is a partially drilled superior lamina. You can see it's a very narrow interlaminar space, and the drilling is then continued further to open up the interlaminar space, and the superior attachment of the ligamentum flavum is then separated out from the superior lamina and detached with a dural dissector. This is drilling of the inferior lamina. It is thinned out and then removed with a Carrison punch, and in the process the ligamentum flavum attachment is detached. This is the drilling of the inferior lamina. This is important to reach the contralateral nerve root. And finally the ligamentum flavum is separated out from all the sides. The underlying adhesions are separated. The flavum is then mobilized as a single piece. This is the separated ligamentum flavum, which is finally pulled out as a single piece to cause ipsilateral decompression. So this is the decompressed dural sac and the ipsilateral nerve root. The endoscope is then tilted to the opposite side. That's the flavum and the dura, the adhesions are broken in between. This is the drilling of the opposite facet. The ligamentum flavum is then detached from the undersurface of the lamina and the spinous process. The flavum is kept intact, and the working sheath is passed over the flavum to protect the underlying dura, and drilling of the contralateral facet joint is done. So after completion of the drilling process, the ligamentum flavum is detached from the opposite side superior lamina and the inferior lamina and removed as a single piece. So these are the remnants of the ligamentum flavum. The thinned out hypertrophied facet is then removed with a Carrison punch to identify the lateral border of the opposite nerve root, traversing nerve root. So once the traversing nerve root is decompressed, decompression of the contralateral exiting nerve root is also done. That's the contralateral exiting nerve root. So this is decompression of all three nerve roots in one procedure: ipsilateral traversing nerve root and contralateral traversing as well as exiting nerve root can be decompressed. So this is the management strategy which I'd like to follow for decompression of lumbar canal stenosis. We first identify whether it's a lateral recess stenosis or a central stenosis or a combination of both. If it is just lateral recess stenosis with unilateral symptoms, I usually like to perform a unilateral decompression with or without discectomy as per need. Whereas a lateral recess stenosis with bilateral symptoms and also in central stenosis, I usually like to operate from the side with more severe symptoms. And here we first identify whether it's a unilateral disc or there is no disc herniation. In these cases, I usually like to perform unilateral approach with bilateral decompression, also called as over-the-top decompression or ULBD approach. Whereas if there is a broad-based disc herniation, or if I feel that the nerve root compression or the radicular pain is because of the disc affecting on both the sides, then in those cases, I usually like to perform a bilateral approach with bilateral decompression through a single skin incision. A few case examples: a two-level stenosis L4-5 and L5-S1 level. Right-sided approach has been done. These are the pre-operative L4-5 level images, and you can see the post-operative MRI pictures. the neural structures are well decompressed and the facet joint is well preserved. L5S1 level again well decompressed ipsilateral as well as contralateral side. And these are the post-operative clinical scar incision pictures showing two separate 8 millimeter incisions for 2-level stenosis. Again, another case of a 65-year-old female right-sided radicular pain with severe stenosis, central as well as lateral recess at L4-5 level. And these are the post-operative MRI pictures showing well decompressed spinal canal as well as preservation of the facet joint. No drain is usually kept on in these patients, and the patients are mobilized the same evening, and we usually discharge in the on the next post-operative day. Another case, central with lateral recess stenosis, preoperative and the postoperative MRI pictures. Another case of lateral recess stenosis, L4-5 left-sided approach, and you can see the widened spinal canal which is seen and the preserved facet joint on the ipsilateral side. This is another case of 2-level lateral recess and central stenosis in a 47-year-old patient at L4-5 and L5S1 levels. The patient was suffering from bilateral claudication pain since 8 months, and there was left L5 radicular pain also. Patient had a normal neurology and there was no instability on X-rays. So similar left-sided interlaminar approach with over-the-top decompression was performed in this patient. So exposure of the muscles, once the endoscope is inserted, coagulate it, remove a little bit of muscle to expose the ligamentum flavum. This is the drilling of the medial margin of the facet and the superior lamina. Drilling of the superior lamina, you can see that all the cutting of the bone, whether it's the kerrison or the drill, is always done under very high magnification to avoid injury to the underlying delicate dura. This is the drilling of the inferior lamina. We use a round burr to thin out the inferior lamina so that it can be easily cut with the help of a kerrison punch. Detachment of the ligamentum flavum, separating it from the underlying dural structures and removing it as a single piece. This is separation of the adhesions of the opposite side between the flavum and the dural sac. Cutting of the ligamentum flavum, which is hypertrophied, with the help of a kerrison punch from below. This is removal of the hypertrophied flavum in the lateral recess. You can use a short or smaller tube sheath punch to remove smaller pieces. This is the axilla of the opposite nerve root, and that's the inferior pedicle of the opposite side, the axilla of the opposite nerve root, and this is the exiting nerve root of the opposite side. So 3 nerve roots can be decompressed at any time during this kind of procedure. So this is the ipsilateral nerve root which is decompressed. Cannular rotation exposes the disc space. This is the bulging disc which is seen. I have not removed the disc in this case because it is degenerated and not actual pathology. Post-operative MRI pictures shows a good decompression of the neural structures with a widened canal and a good decompression of both ipsilateral and contralateral side. What you can see here is the collection of fluid because the MRI has been done immediately post-operatively, and this gradually resolves with time. And if you take an MRI after a few weeks, the cord will appear to be expanded. So these are the CT scan pictures showing the facet joint preservation on either side. So over drilling of the facet has been avoided, and this is the drilling of the inferior margin of the superior lamina at L4-5 level. If you look at the 3D reconstruction, you can see the widened interlaminar space in the caudocranial direction on the left side, and if the space is same on the other side because decompression of the opposite side has been done under the lamina. Only the bony structures which are protruding and compressing the nerve roots have been removed, whereas the rest of the lamina has been kept intact. So to summarize, full endoscopy is a sophisticated and a highly evolved form of minimally invasive spine surgery. Although technically demanding, it is a very safe and effective procedure. It offers trifold benefits of illumination magnification as well as clear field of vision due to irrigation, which is absent with a microscope which offers only illumination and magnification. It has all the advantages of minimally invasive spine surgeries like less access related trauma, less hospital stay, less post-operative pain, and early return to work. And it is particularly effective in contralateral decompression with less complications as compared to microscope. Thank you.
So thank you for a good overview on the decompression. So again, continuing with that learning curve, when do you think it is right for a surgeon to go into the decompression part? Because it requires much. It is much more challenging. It requires much more mobility. You need to be much more aware of the situation compared to a discectomy. So when do you think a surgeon should venture into the decompression? What time, like in terms of his learning skills, and in terms of like maybe after doing 30 discectomy, maybe you should attempt, or anything you can give based on your own experience with decompression.
I think it should, when you're starting interlaminar procedures, always start with the L5S1 disc where the bone removal is not much. Then the next step is start doing discectomies at interlaminar discectomies at L4, 5 level, where you just need to drill the little bit of medial margin of the facet. And as you become more and more experienced, I think this number is all, it depends it's very individual. Like some people, they may start doing stenosis decompression after 20 cases of interlaminar discectomy, whereas some people may take around 50 cases. But I think it is the level of confidence which you are having, and if you learn the technique correctly, if you learn to handle your instruments properly without damaging the underlying structures, especially these instruments can be very dangerous, the drill or the caissons. If you're not able to use it in a correct manner, then they are more harmful than beneficial. So learn to handle the drill properly, learn to get the idea about the extent of the decompression. You need to, because you're looking from a very close distance at the entire pathology, and because of that you are completely lost many times. You don't know where you are standing, and it's very important for us to identify the uh, craniocaudal level of decompression also, but also the mediolateral level of decompression. So that all has to be, you need to get that kind of judgment before you start venturing into decompression of stenosis. Your voice is muted, I think. Ayush, yeah.
Yeah. Am I audible now?
Yeah, yeah.
Yeah. So the next part of it is how easy or difficult it is to manage a endoscopy drill, because that is very, very handy when it comes to decompression. And even if you work with a normal drill, the endoscopy drill is a bit difficult. It's a bit different. So what are your tips and tricks to overcome this challenge of using it in a very, very effective way? Because we need to use it in a much more effective way in order to accomplish what we want to do when it comes to decompression through endoscopic drill.
Yeah, first of all, if you look at the the shape and the size and the weight of the endoscopic drill, it is much heavier as compared to what we use in the open procedures. You compare it with mid-aspect drill. Mid-aspect drill is a very light drill, whereas the handle of the the endoscopic drill is very heavy. It's like what we use for the shavers in arthroscopy. Secondly, it's being vertically used, so gravity definitely plays a lot of role in making the things more difficult. Third thing is the length of the drill burr, the length of the burr tip. It's quite long, and because it is long, if you don't have the right kind of drill, if it is a cheaper variety or a local made variety, there is a lot of wobbling around. The wobbling of the tip happens, and that may be very dangerous. So choose a good quality drill. Third thing which I feel is is getting the feel of it. Not only you should be able to stabilize the drill with one hand along with the endoscope and the working channel together. That entire assembly needs to be working as a single piece. So when you're drilling, you need to do sideways movements rather than vertical up and down movements. So up and down movements can be very dangerous. They can just go in a fraction of a second. They can go inside and penetrate the ligamentum flavum, and they can just injure the root or the dural sac inside. And these injuries of a moving drill, they can be catastrophic. They are very dangerous, especially in very difficult to operate areas like thoracic or cervical spine. So it takes a lot of practice, and that is why I always say that do a lot of interlaminar decompressions using a drill. Always see to it that all your bony work is done before you are opening up the ligamentum flavum. So finish all your, don't use, especially for newcomers, don't use a drill after you open up the ligamentum flavum. So these are a few tips and tricks, and if you don't use it in a proper way, the tendency for the drill bit to break is very, very, very common. So most of the times initially we used to break the drill, and it's very expensive. I think our reverse point drill bit costs around 35 to 36,000 rupees. So if you break it, I think the expenses add on. So all these things need to be done in a very stepwise manner.
Thank you,
There's
Dr.
one question from the audience. So I'll just give it to Dr. Bhanot to answer about how to start training in endoscopy after completing open and MIS fellowships, and how much time it will actually take to start the endoscopy practice. It has
Pratik,
been
I
asked by
already
Dr.
answered.
Pratik Patel. Yeah,
I answered it on the chat. I'll just, for the sake of the
the
rest
chat
of the
answer actually does not go to him. We will have to answer him. Yeah.
Okay. So it is recommended to start your introduction to endoscopy from these kind of events, which are being organized now very regularly because of the great interest shown in this branch. Then to get hands-on feel, it is important to learn from the cadaveric courses nowadays, which are very regularly organized, where you get a small number of candidates per cadaver, and there's a one-to-one faculty interaction where you can clear all your doubts, and right from handling of the instrument, right from how to hold a needle, how to advance it, and how to position the patients, all those things. And once you gain that kind of confidence by attending few events, ideally it is better to go for a structured fellowship or at least an observership training program for a few weeks to few months. But if you can't afford that due to your scarcity of time, then these are the alternative methods. And it is important to have a good liaison with a mentor surgeon, where you can raise your doubts, you pick up a case, and then you see that whether that is suitable for with your experience or not. And most important is that if at all you do not feel that you are succeeding, do not hesitate, do not carry on with the ego that you have to do it with the endoscope. Always have sufficient skills to operate the patient and do the surgery under any circumstance. That is a basic must all the time.
Thank you so much for that excellent tips and tips on decompression. And moving ahead, we will have the Dr. Shivkumar talk on tips and tips for avoiding dural injury is in endoscopic decompression. Let's start with the video.
Good morning, everyone. Today I will be discussing about tips and tricks for avoiding dural injury spine surgeries. So everyone knows about the dural injury is a dreaded complication for any spine surgeon. Most commonly we see the dural injuries along the either the exiting route, traversing route, or the central canal, especially the thecal sac in endoscopy. So when we say about full endoscopy, it's two techniques we use. One is the transforaminal full endoscopic surgery and interlaminar full endoscopic surgery. Coming to transforaminal, most of the time common causes of dural injuries are the wrong placement of needle, blind entry into the foramen during foraminoplasty or access to the foramen area to see the traversing route, recurrent disc surgeries, previously open surgery has been done before using sharp instruments where we fail to identify the structures and we cut, then we develop dural injuries, or excessive epidural bleeding where we tend to coagulate more and might cause dural injury. So most of the time needle placement is very important when we go transforaminally. Always keep idea of safe triangle of Cambins where it's between the traversing route and the exiting route. Needle placement should always be in the safe triangle for any beginner to avoid dural injury. If we pass the needle in such a way, you see the red line, what happens? You are violating the Cambins triangle and might injure the exiting route. Or if our needle placement in lateral view is too shallow, that is just below the facet and AP are already gone medially, this type of placement might again is outside the Cambins triangle and might injure the traversing route. The second commoner injury we see in transforaminal technique is using the reamers blindly under the C-arm guidance or the trifines under the C-arm guidance where we try to remove a part of facet to gain access into the foramen or into the disc or to remove the fragment might cause injury to the either traversing or exiting route, and if patient excess local anesthesia or GA is given, patient might have dreaded root injuries. So how to avoid this? Always follow safe drilling under visualized mode. So you put a scope there with either a straight drill or tip control drill. Always drill the bone under visualized technique so that to avoid dural injuries. So one of the most common dural injury we see is in recurrent disc surgery. When a patient has underwent a open surgery before and we want to do endoscopic spine surgery, and this such patients going through the interabdominal route again might be more risky. So in such cases always uh, going transforaminal, that is a virgin area, is always safe. So you see the case 1 is L4 L5 disc on the left side, and case 2 can see there is a disc laminectomy done from L1 to L5 here, and patient has L4 L5 recurrent disc and also L1 L2 disc. Such cases always go safer is to go interlaminar transforaminal rather than interlaminar. So you can see the case 1 and case 2, the big scars, and we have gone transforaminally here to give the desired result. You can see the excellent result can be attained by transforaminal route, but always keep in mind, even we go transforaminally, we should be very careful not using a sharp instrument to cut. So the other injuries, especially the interlaminar dilator placement, cutting the ligament flavum, or retracting the traversing root before properly drilling the facet, and axillary fragment is there between the traversing root and the thecal sac, and especially stenosis surgery has more incidence of dural injury. So again the three zones are more common here. Zone 2 is more common in interlaminar stenosis surgeries. So when compared to transforaminal, interlaminar full endoscopy has more injuries. So how to avoid it? When you are placing the dilator in AP, once we pass the muscle tissue and the fascia, always take a C-arm shot in the lateral image and push the dilator in lateral view so that we can avoid plunging of dilator into the thecal sac in the interlaminar space. The second is the most commonly is the ligament cutting. When we are cutting the ligament, so we might injure the ligament. Cutting the ligament, we might injure the thecal sac. So when we always rotate the scope and cut in a visualized manner. So whenever you want to cut, you cut in a visualized way. So always be safe and see what we are cutting so that to avoid thecal sac injury. Next is the axillary fragment. Whenever we are dealing with such fragment, the fragment is in the axilla, so going transforaminal in this route is difficult. So always interlaminar approach should be followed to avoid dural injuries. And secondly, when we are exposing interlaminar, always try to see the always try to see the traversing route. If not possible, first debulk the some disc material, then you try to always identify the traversing route, otherwise you might land up in a tear like this. This you can see here, auxiliary dural tear. So what to deal with such when there is no rootlet sprouting out, you can just repair it using a, you can just use a dural Duragen patch where you can just place it there on the dural tear, because here there are no roots coming out, and most of the time we are doing through endoscopically, the opening is so small that there is no need to open or repair. But when rootlets are out, definitely yes, we need to convert it and repair. And the second thing is the traversing route. Dural injury can notice that there is a dura has torn there. Such cases also, what you do is just because the tear is so small, you can just place the dural patch like this. So this works very well, and this tear is a central dural tear we see in stenosis surgeries. So such cases, what we do is when arachnoid is intact, you need not convert it. You can just place a Duragen plus and safely come out. So because we are dilating the muscles here, we are not cutting the muscles, and opening is very small, so there is no need for dural repair. So take home message, whenever you identification of dural defect is very important for both long and short term prevent adverse effects. Incidence of dural injury is more with interlaminar technique, so more care should be taken. In case of large dural injury, have a very less threshold, convert it and repair the defect. Identify the structure before cutting, and overall, when you compare the endoscopic techniques to other techniques, the incidence of dural injury is very less. Thank you. Thank you very much.
Thank you, Dr. Sukumar. Very nice presentation. If Ayush, if you permit me, I'll just ask him a question.
Yeah, please go ahead. No problem.
So my question is that when open the dura, when we open the ligamentum flavum, make an opening in to expose the dura. When we do our normal by the tube or microlumbar discectomy, we are always worried that the dura may be adhered to the ligamentum flavum, and we try to separate it out before we open it completely. Uh, how do you take care of releasing those adhesions, or if any, because you can't see it initially when we do a endoscopic flavectomy?
Yeah, one thing here, because we are working under lot of magnification and the scope is very near to the ligament. So the safe technique is to first is thin out the ligament with a multi-layer technique. You keep on cutting the ligament, the layer by layer. Once you see that definitely the moment you are near to the thecal sac, it because the color of the ligament changes. You will see a layer of a bluish tinge or a pinkish tinge. There you stop and try to push the sleeve further inside so that it makes the ligamentum flavum more tense or taut. So then you can, if you are confident enough, you can safely cut with the punch. If you are not confident, I always tell the beginners or any person who is starting this endoscopic interlaminar technique, use a blunt dissector as we do in microscopic surgery when we just try to make a rent in the flavum. So you just tease, already you have thinned out the flavum there. You just tend to tease the flavum along the superinferior direction. You just feel a giveaway, a small giveaway. Once you have done this, you just pass this dilator all around, the dissector all around, then you are easy to cut. Make a small rent. Once you make a small rent, because of the saline irrigation, the pressure thecal sac is pushed away automatically. So it is very safe. Most of the time, nothing happens. But when you are cutting the flavum, always visualize and cut. Otherwise, you might take a pinch of dura in your punch, and you might injure the dura. So definitely, your concern is always there. So whenever you are opening, better to be safe, go layer by layer, cut in a small bit so you are more safe.
So, other than this, Dr. Srikumar, what is will be your another tip for a beginner to avoid the dural injury? Because people are really scared of sort of starting with endoscopy, and that is the inhibition they get because it's a mobile system. So, what will be your tip for a beginner when he's starting? What he should do, or what maneuver he should avoid, or what maneuver he should execute to avoid dural injury during the beginning curve of his career?
As Dr. Lokande and Banoth said earlier, always choose the case if you are starting your career as an interlaminar endoscopic surgeon. You choose a case with a wide interlaminar space, simple disc, so where the ligament is not very thick. So in such cases, what happens? Your entire sheath is sitting on the ligamentum flavum very nicely. The whole oval shape of your sheath, you see only the ligamentum flavum. So in such cases, you are not confused. Your your ligament is taut, so it is not moving. So your sheath is snugly fitting to the ligament. In such cases, what happens? There is no bleeding percolating from the sides, and ligament is evenly stretched. In such cases, when you start cutting with your cutter, it spreads away. The fibers are taut, so the ligamentum flavum, once you cut, they spread out. So here you are more safer and start from medial to lateral, because medially you have some epidural fat, so it is safe from when you start from medial to lateral. But when you choose a case where there is little bit of ligamentum thickening and the window is not wide, then your sheath doesn't sit snugly in the space, and you start cutting the ligament. Sometimes bleeding starts trickling from the side, from the muscle, or from the small vessels over the ligamentum flavum, and you get lost. And you try to cut, and when there is a bleeding, you tend to not see what you are cutting, and you might injure. So always better is choose a case which is having a wide interlaminar space with a thin yellow ligament. Once you are confident, you are done, you know how to handle the bleeding and you know how to drill well, then you can go for L4, L5 or L3, L4 levels where you are confident in cutting the ligamentum flavum and removing it. The another point I want to add is when you are trying to do an interlaminar case, the bleeding is a big issue. So as a beginner, if you don't know to tackle this bleeding, there will be sometimes torrential or very heavy bleeding from the intramuscular tissue. So if you don't coagulate that vessel which is bleeding, then it keeps on trickling into your field, and you don't have a proper pressure on the saline irrigation, then you tend to get lost, and chasing that bleeder, you might go superiorly or inferiorly, and you might even go to the next space. So for a beginner, learning how to control a bleeding, having a proper radio frequency system is key to have a safe and a good surgery. Otherwise, you get depressed and you get demotivated not to go further learning endoscopic surgery.
So one
Thank you
question
for
to
those
the
explanations. Please go ahead.
may
Thank
I ask
you.
one question to the experienced panelist over here. When do you decide to open and actually do a suturing of a dural tear in an endoscopic surgery? We can take the question from, we can start it from Dr. Banod sir and ask Dr. Ajay Krishnan or Dr. Pradyumna who is around.
So, Sandeep, in my experience, I do not recall having to convert an endoscopic dural tear to do an open repair, fortunately, because most of the tears I have encountered have been small tears without the rootlets coming out, as Dr. Sukumar very clearly said. And as it is a closed system, if you go back a few decades earlier when we didn't have the microscopes to repair the dural tear, what was the method? You do a watertight closure. Here you get a watertight closure automatically. The moment you take your cannula out, the tissues are giving you a watertight closure, and you have to just ensure that you have a good skin suture for small tears. But if there is a rootlet, then of course you have to take out the scope, then you have to open it, put the rootlets back, and then do a proper dural repair under microscopic magnification. And I also use sometimes to seal at the end of the procedure if I feel that the tear may be a problem, source of problem in future.
Dr. Sandeep.
Any? Yeah, Dr. Sukumar, you wanted to add something?
Yeah, fully agree with Dr. Banot. So the chance of dural injury in endoscopic, full endoscopic techniques are much less because of the vision we have, the clarity of the vision because of the saline irrigation we have. But yes, sometimes it do happen in early phases, early part of our endoscopic career. It do happen. It has happened to me also. But always prepare the patient. Like when you are not confident and you think you might injure, always prepare the patient that if something happens, I'll convert it and repair it. So I had two cases in my career. So I came out of the theater, spoke to the relatives, and I converted into microscopic surgery and repaired the dura with some patches. So, but this one is to all endoscopic enthusiasts is keep very less threshold to open and convert your surgery and repair, because ultimately patient safety is important rather than our ego.
Yeah, and I think in our one of the cases, that in the initial cases, we landed up with a dural injury because of improper docking of the sheath, especially in transforaminal approach. Because if we don't have the correct judgment of where the medial pedicular line is, sometimes you can tend to overdo it, and that can cause the dural injury rather than when you're actually seeing the dura. There's very less chance of you landing with the dural injury. So your take on that, Dr. Manoj?
So just to add to Dr. Sukumar, I have been doing endoscopy for more than 1.5 decades, but I still tell all my patients without exception that if need be, you may need to be converted to a microscopic procedure. So that goes without fail to every single patient. Two, you were asking about transforaminal surgery causing. So whenever we learn or teach transforaminal, the critical border is medial pedicular line, and you should always visualize it before you start doing your procedure. And you should make sure that your interspinous space, the spinous process is exactly in the midline. The two pedicles are equidistant. Whatever position of the C-arm it takes for you to achieve that, you should achieve that at this concerned level. And then medial border of the pedicle in AP view should be your benchmark, that you will not cross it unless and until you have entered inside the disc space, which is with the you have gone anterior to the posterior vertebral line. So only if you follow this rule, you will never injure the dura.
I think that's a very, very interesting point that you made, because pre-operatively, in a hurry to dock the scope and get going on with the procedure, we frequently tend to neglect these points that, pre-operative visualization before you start the case is very, very important for these cases. Sorry, Dr. Banot, I interrupted you. Wanted to complete something on that.
No, that's
fine. So any more questions, Ayush, or we can move on now? So I think we move on to the next session on unilateral biportal endoscopic decompression, and we have a video presentation by Dr. Ketan Deshpande.
Yeah, I think I've sent the video. Yeah.
A very good evening to all. Firstly, I would like to extend my gratitude to the organizing committee, Bombay Spine Society, for giving me this opportunity to present my work here. Myself, Dr. Ketan Deshpande, and my topic for presentation is unilateral biportal endoscopic decompression. The name indicates it's unilateral biportal. So there are two ports which are on the same side of the midline, hence biportal, but still unilateral. There are two ports which are scopic, which is used for vision. And the second one is a working port, which is used for the passage of the instrumentation. It's a water medium surgery wherein there is a continuous flow of irrigation going in from one channel and coming out through the other channel. As you can see in this picture, the yellow dotted line marks the tip of the spinous process, or in other words, the midline. The red line is the level of the disc. So there are two ports which you can see, which are on the same side of the midline, that is the same side of the yellow line, but one is above the disc level and one is below the disc level. So the left-sided one is the scopic portal, the right-sided one is the working portal. The pictures onto your left-hand side, the first and the second picture, you can see that below the fascicles of multifidus muscle, there is a potential space which we have to convert into a working space. Unlike any joint where the joint cavity is confined by a capsule and you get to utilize that full space just by inflating that particular space. Here, there is a potential space beneath the fibers of the multifidus muscle, and you have to convert it into a working space, and then you have to perform the procedure. As is seen on in the third picture, that red triangle that marks the potential space that needs to be converted and gradually expanded to work your way through it. This figures indicate the way the scopic and the working portals align with each other on top of the interlaminar space. And the picture onto your right side shows the flow of irrigation fluid, which is connected with the scopic portal. It goes inside, it accumulates over the working channel, it stays there, creates a pressure, and against gravity, it comes out through the other portal. So this pressure of the irrigation fluid is what keeps the space potent, and it allows you for the easy passage of instruments and to do your decompression or discectomy, whatever work you have planned to do. So this is a very crucial video wherein you can see that the fluid is coming out very freely and very efficiently. So unless and until you see this kind of a picture, you should not begin your first step. And mind you, this is just a gravity-aided irrigation fluid. No irrigation pumps are used in this particular procedure. There are some specific instruments that are required for this particular procedure. First and foremost is a 4 mm scope. The scope can be either 0 degree, 12 degree, or 30 degree, depending on the availability and your choice. You of course need a video trolley. You need a good shaver and a burr system. You need a radio frequency cautery. You need some specialized instruments as is seen in the picture onto the right side. Plus all the instruments that are used in open spine or MAD or tubular spine surgeries can be used in UB. So there's no need of any fancy equipments here. This is how we position the patient. So there are two bolsters placed horizontally, one at the chest level, one at the level of the iliac crest. We make sure that the abdomen is free. All the pressure points are well padded, and either with a silicone gel foam or with some sort of cushioning. And it's just a regular positioning, nothing special about that. We use two vertical to horizontal drapes to keep the surgical site open. And after that, as you can see in the video, we use a specialized drape, which has got this IO-band like sticking in the center, and it continues all 360 degree to get converted into a fluid collection pouch. And this pouch itself, this is how it looks from the top view. This pouch itself accumulates all the fluid that is coming out, and it's very easily, there are two outlets for that pouch, and those can be connected directly to an irrigation bag, and that's how it looks at the end of the draping. So I prefer my CM coming from the opposite side, right from the middle. The CM trolley is on my left hand side and the video trolley is on my right hand side when I'm standing on the left side of the patient. So let's just jump into the case. She is a 67-year-old female patient, came to me with right lower limb pain and a neurologic claudication, was not able to walk for more than 3 to 4 minutes. She had a list which was progressive in nature, and it was making her unable to stand also at one given place for more than 10 to 15 minutes. She did not have any distal neurovascular complications. This was her MRI. Both the sagittal and the axial section seen on in T1, and these are the T2 images. So if you look at the MRI carefully, there are three main issues that need to be addressed here. First and foremost is the lateral recess stenosis at L3-4 level. Second is the central plus right lateral, bilateral right more than left recess stenosis at L4-5 level. And she's got a huge right-sided extraforaminal disc herniation at L5-S1 level, which is completely extraforaminal disc herniation. So while performing this procedure, all the three issues were addressed. But for the sake of presentation, I am only going to show the central L4-5 decompression surgery as a part of this particular presentation. So we begin by marking the midline. Then we mark the lower pedicle, which is going to be our working portal. We confirm it in the CM. We mark the midpoint of the lower pedicle. Then we mark the upper pedicle at the target level, the lower part of the upper pedicle, approximately 2.5 to 3 centimeters away from the scopic portal. That is going to act as our working portal. Now we go into lateral view and we put two obturators which are seen on lateral view like this. So the scopic portal is in line with the disc, whereas the working portal is slightly obliquely coming to the disc. Then we take the skin incision, which is approximately 1 to 1.5 centimeter. We cut the skin as well as the fascia. We use an obturator and we directly dock onto the upper laminospinal junction. So if you're talking about L4-5 level, the docking point would be the L4 laminospinal junction. Then we dilate the track and we do these kinds of movements wherein the laminar, the interlaminar, and the lower laminar space is created. And these are all the soft tissue dissection or the movements that are required. Then you go for the scopic portal. You take the second incision, which is 5 millimeters. You take the skin incision as well as the facial cut through which the trocar and the cannula go inside. You touch the tip of the two instruments and you make sure that you're still at the upper laminospinal junction on the ipsilateral side. We confirm it on the C-arm. Once we do that, we do this kind of a waddling movement, which creates kind of a passage for the, it creates kind of a passage for the flow of irrigation fluid so that it goes in from one end and comes out through the other end. Then you connect the irrigation fluid and you connect the scope and we go inside. So once inside, the initial part of the procedure is always slightly challenging because you have to actually triangulate those two instruments. So the initial part is very crucial, wherein you are using the radio frequency tip, but not actually coagulating or cutting anything, but using it as a blunt probe to have that tactile sensation of being on the lamina, sliding over the interlaminar space, the upper lamina, the lower lamina, and making sure that the tip of the radio frequency probe is seen, visualized. So this initial part is very crucial, wherein you do some blunt dissection. And once you visualize the actual tip in front of your lens, then you start working and then you start coagulating the soft tissue that is there and you start clearing the upper lamina. Now when the lamina is clearly seen, you start moving laterally as well as medially. Medially, you will find the base of the spinous process, and that's the base of the spinous process. You confirm it on CM that you're still at the same exact point where you're supposed to be. So that's L4 laminospinal junction on the left side. Now you start exposing the whole length of the lamina. By that I mean from the spinolaminar junction up to the medial border of the facet joint, and both the upper and the lower margins of the lamina. Both the edges, the ventral and the dorsal edge of the upper lamina, need to be clearly exposed, and then only. So the red line here is indicating the spinous process, the black line is the lamina, and the yellow part is the junction of the 2 point, and that is the orientation: left side cranial, right side caudal. 12 o'clock is medial and 6 o'clock is lateral. Once you do that, you start burring, and this is a special shaver with an which allows the irrigation fluid to be sucked out intermittently or continuously, depending on how you control it. So you have to adjust it slightly so as not too much of soft tissue is popping in, but the vision still remains clear. So initially you may get these kinds of hazy visions sometimes, but once you get a hang of it, you can adjust the outflow intermittently, and you can always use a soft tissue dissection in the form of radio frequency cautery. If you are able to pass a Kerrison-like instrument, then definitely blunt dissection and removal of the lower edge of the lamina is preferred. But the angle with which we come towards the lamina, the upper edge or the dorsal edge of the lamina, is difficult to remove. So I prefer using a burr for removing that lamina. So edge to edge work is being done, and we do this till we visualize midline ligamentum flavum split. So that is the point where the right-sided and the left-sided ligamentum flavum, they are coming closer together, but there is a deficit in the midline. So that is the end point of bony decompression as far as the cranial to caudal bony decompression is concerned. We do dome cut the undersurface of the spinous process so as to facilitate the passage of the instruments when we want to go to the contralateral side or when we want to do the over the top decompression. So intermittently we wait, we allow the bone dust to come out, and we keep on using the burr simultaneously. Intermittently we also have to use the radio frequency cautery because the periosteum layer of the lamina is not cut with the help of a burr, it is just getting retracted. So to keep a clear vision, intermittently radio frequency cautery and burr is to be used. So this is the point where the ligamentum flavum is deficit in the midline, and that will mark my end point of laminotomy, ipsilateral laminotomy. And from this point onwards, I will start working on exposing the epidural space. So there are two ways of removing ligamentum flavum. Either you can take care of, or you can detach it from all the sides and remove in toto. I personally prefer removing the superficial part of the ligamentum flavum first, because as we all know, the origin of ligamentum flavum is from the lower lamina and the upper border of the lower lamina. So it's very easy to detach it without worrying too much about the neural structure, as the deeper layer of the ligamentum flavum is still intact. It is going to protect the dura. So it's very easy to detach it from the bone and also separate it from the lateral aspect from underneath the facet joint. And such large chunks of ligamentum flavum, once freed from all the sides, can be very easily taken out using disc forceps. As far as the deeper layer of ligamentum flavum is concerned, I prefer using a blunt instrument like a Kerrison Ronger, a 45-degree upbite, wherein I use the base plate of the upbite to actually push the dura downwards, which is already pushed by the irrigation fluid, and create the space between the ligamentum flavum and the thecal sac itself. So once I create that space, I take small bites and remove the deep layer of the ligamentum flavum in small bits and pieces. We continue doing that from midline to the ipsilateral side, as long as far as the lateral margin of the thecal sac or the shoulder of the traversing root is visualized. So this dissection is continued on the ipsilateral side. You can notice here that since there was an extreme amount of stenosis, the dura doesn't look healthy. Normal dura would have a pinkish color with a lot of blood vessels on top of it. But I think because of too much of tight stenosis, this dura had become completely white. And as you will see towards the end of the video, once we complete the decompression, it just turned pink, and all the blood vessels can be seen very, very clearly. So once you do that, once you do lateral recess decompression on the ipsilateral side, then it's time to move to the contralateral side. So that's almost the last piece of the ligamentum flavum being removed on the ipsilateral side. Yeah, so that's the base of the spinous process you can see in the midline. And now when you want to go to the contralateral side, you just have to insert a blunt dissector between the contralateral lamina and the ligamentum flavum and just detach the ligamentum flavum all the way from midline right up to the facet. So my tip of the blunt instrument is feeling the facet joint on the contralateral side, and I'm just detaching it. Also, I need to make sure that there are no adhesions between the dura and the ligamentum flavum on the contralateral side, which can get pulled when I'm trying to remove that flava. So both upper and the lower part of the flava are completely freed. And now you just need to engage your Kerrison punch, lift the ligamentum flavum and pull it. So under vision, you can just keep on pulling it. You can actually see the dura being separated from the ligamentum flavum and reduce the risk of accidentally catching dura and causing a dural tear. So you can very easily do this till you go up to the facet joint. Once you are at the facet joint, it is quite possible that the traversing root might be pushed posteriorly and you have to be a bit more careful. Again, I'm doing some amount of blunt dissection to feel and visualize where the facet joint is. So that's the actual facet joint you can see there. And yeah, that's inferior facet, superior facet, and the orange line itself is marking the facet joint. So now once I've come to that point, that's the point where I can start retracting the dura, because I know that's the lateral extent of the thecal sac, and that's the shoulder. You can see the traversing nerve root on the contralateral side. So you put a retractor, hand it over to your assistant, and then you do the annulotomy, because there was a disc bulging at the shoulder of the contralateral nerve root. So you do annulotomy. You use these kinds of blunt tip probe to remove all the disc. This is not, I think this is a chronic disc. That's why it's not a soft, juicy or a single fragment, but a dehydrated kind of a disc. Whatever loose pieces you can find, definitely we have to remove all those pieces. And the bulging portion of the annulus, that needs to be flattened down, so that you can be assured, since this patient has a right-sided radicular symptom, I wanted to be more sure that I don't leave anything behind that can compress the dura or the traversing nerve root. And once you release that, now you can see that that bulging portion of the annulus is gone now. And now you go to the contralateral lateral recess, because if you do this step before you remove the bulging portion of the annulus, you might be putting too much of pressure on the traversing nerve root. Once you flatten the annulus, now I feel it is much more safer to go to the contralateral side and remove the lateral recess ligamentum flavum and achieve complete decompression of the lateral recess on the contralateral side. So once you do that, you also have to check the foramen, and you have to make sure that there are no bony spikes or nothing hindering the nerve root. So you try and pull the nerve root, you can see that nerve root nicely going into the foramen. Then you go and do the annuloplasty. So any loose fragments can still come out, or the portion of the annulus that is just hanging there, you can do a radiofrequency annuloplasty and make sure you can reduce the chances of recurrence or any soft disc herniation coming out again. So you can just harden the disc. Now you come to the ipsilateral side and you check the traversing nerve root on the ipsilateral side. So that's the shoulder of the traversing nerve root. You can see that's easily retractable, not much of a disc bulging there. So that's the contralateral nerve root, the axilla and the shoulder and the ipsilateral nerve root all in one piece. Now you can see that the dura looks quite good, pink in color and the normal color and with the blood vessels and everything. I usually don't put a drain. I just put in an Abgel and just come out. Of course, this was not a single level decompression. So the first picture is for L4-5, then we went to L3-4, did bilateral lateral recess decompression, then we came down to L5-S1, did the contralateral discectomy. You can see in the third picture on the right hand side, you can see my disc forceps going almost beyond the facet joint on the contralateral side. So contralateral extraforaminal discectomy is being done here. And this is the final picture of the incision. So single level will require 2 incisions, 2 level will require 3 incisions, so 3 level will require 4 incisions. So 4 incisions, approximately 1 to 1.5 centimeters each, and that's it. That's the whole incision that was taken for completing the decompression procedure. So I will not enumerate the advantages of UB again here, but I would say that we need something like an MED or a tubular decompression technique, which has a vast era of including multiple pathologies, and it gives you a wide spectrum of it covers a wide spectrum of diseases. But you also need the vision of uniportal endoscopy and the water medium surgery, wherein your eye is actually inside the body of the patient. And you can visualize the anatomic very, very clearly with the pressure of the irrigation fluid. You can be sure that there is, at least you saw the video, there was hardly any bleeding there. So what we are trying to do here via UB is combining the versatility of MED or tubular decompression and adding the vision of uniportal endoscopy, but keeping the familiarity of the interlaminar approach, which all of you spine surgeons are very well versed with. So nothing new as far as the anatomic is concerned. So you combine these two and what you get is called as unilateral biportal endoscopy. I again want to thank the organizing team for giving me this opportunity. And definitely, if you have any doubts, please, I'll be very happy to answer your questions. Thank you very much.
Excellent demonstration. So like again, why should, again, like it's a cycle, you learn a full endoscopy, then go to this. For you also, I know that you used to do a lot of full endoscopy and venture. What was the reason? What drove you to this? Do you think, like, and then we can have the debate, because it is, no, because it's another technique, knowing another going through the whole cycle. So you have gone from doing full endoscopy to this. So what were the reasons behind this? Because it's not easy to adapt a new technique and then master it.
The main reason for me to shift from interlaminar to UBE was the ease of approach of UBE and the economics part of it. So with all of us orthopedic surgeons having doing scopy procedures, any joint scopy procedures, you all have a shaver system and RF system and an arthroscope at your hospital. So it becomes very easy. You use all that, and with all the rest of your open spine surgery, you can just do this procedure. Secondly, I don't know whether it is a mental block or it's a reality, but unless and until you see and feel and retract that nerve root, I don't get that much of confidence whether I've done an adequate decompression part or no. And thirdly, if you have multi-level pathologies, that includes multi-level stenosis or instability also, that can also be taken care with the same approach, wherein those two ports itself can be utilized for the insertion of an interbody cage and then followed by percutaneous pedicular screws through those two incisions. So UB is providing quite a vast array of pathologies to be covered with. So I think that was the main reason. But I still do transforaminal. It's not like I completely shifted from uniportal to biportal. I do transforaminal in selected cases, but as far as interlaminar approach is concerned, I've completely shifted over to UB.
Dr. Ketan, just one question I wanted to ask you. When we talk
Yeah.
of interlaminar approach, we always have this concern that the scope should not plunge into the canal. Now here you have two portals over there. How do you manage to control it? Or you have one person holding the working cannula, or it self-stabilizes and you work through it? How do you control it with two hands?
So the scope here is not a working channel scope. The scope is just an arthroscope that you would use otherwise in a joint scopy. And the instruments are going from a separate portal.
Self-stabilizes over there? It self-stabilizes?
No,
or supposed to hold
I am
it?
holding it. I am holding it because I want, whenever I am burring, so I want the tip of my instrument to be kept in the center all the time. So it is kind of a live triangulation, you can say. But there are very slight fine movements. Most of the times my hand is steady. So I just stabilize it by putting my hand, something underneath my hand and resting it onto the back of the patient and just tilting my wrist joint. That's it.
My question was, you put in a scope and you hold the scope. You put in a working channel, and do you hold the working channel or it just stays over there?
No, there is no working channel, sir. You put in a scope, you hold it. And the second part, you can put a semitubular sleeve, which has got a lip-like structure, which is resting on the skin itself, or you can directly go through the skin percutaneously, because the irrigation pressure fluid itself keep that channel patent. You don't need a second tube or anything for this.
So let me just clear it out for the sake of myself and the delegates. You have a scope which goes inside right up to the lamina, and you have a working sleeve, because you showed that procedure where you keep on creating a channel. So you have created a space, and the working sleeve is going to dock inside, or whatever you call it, and that is going to be independent of your instruments, right? So that is what my concern was, that you have one scope, but you have a sleeve which is fixed.
It's not a tube. It's not a tube. It's a semitubular thing. So it doesn't restrict the size of your instruments. And even if you don't have that, you can directly go in from the skin without putting anything at the working channel.
Doesn't
directly
it do
through the skin?
Doesn't it do any muscle damage every time you're getting the instruments out and putting it inside?
So that is what the channel that you have creating, the initial dilation of the track and the initial movements that I had shown. That is what creates the space, and the irrigation flow itself keeps it patent. There are multiple options. There are people who have been using those plastic cannulas used in shoulder scopy and putting it there. But then again, they have a certain diameter and they restrict the size of your instruments. So I personally don't prefer using those circular cannulas.
Right.
So any comment from those who do a full endoscopy? How do you see it? Maybe Dr. Banot or maybe Dr. Ajay Krishnan can come in, because it's a debate between two technologies, and I think most of it is very self-driven. I think Ketan is very comfortable and he can give excellent results. But maybe those who still pursue with the full endoscopy, why don't you go to this?
I think Ayush, it's a very good technique for beginners also, as Dr. Ketan said, because we have a better orientation about the whole thing. We are almost doing an open surgery with visualization, so it's a good blend of both. But there are some concerns which I initially mentioned, and obviously we can have view of the other panelists also. So, Dr. Banot, would you like to?
So if I look at it, when you're doing the UBE, you are still doing exactly the same thing, that the steps, as Ketan said, are similar to your microscopic surgery. Now, when we are talking of minimally invasive surgery, there are multiple yardsticks to measure. One is you have good optics. One is, are you cutting down on your tissue dissection or not? For a pathology of disc herniation, where your aim is only to remove the disc, if you have to still remove the whole of the ligamentum flavum using this, then particularly in my hands, I do not approve of it. But when it comes to stenosis, especially of more than one level, where the ease and the quickness can be added to the surgical technique, definitely it stands its role. And especially when you are doing a fusion, again, it adds value. Short of these two indications, for standard disc herniations, probably interlaminar approach still holds its place and still will remain preferable.
Yeah, I would like to add some more points. Yeah, Sandeep, can I speak?
Go on. Please, Pramod, please.
Yeah, couple of things. I think it is more damaging for disc herniations, as Arun just rightly said. Secondly, I think if you look at the muscle, while you're inserting the ports, see the amount of elevation, muscle elevation you're doing you're moving those zigzag movements to create that single channel which with the endoscope on one side and the working channel on the other side. So that is a lot of muscle damage. It is not so muscle preserving. Thirdly, I would say that now if you have a left-sided approach, it's very easy for an operating surgeon. For a right-handed surgeon, your working instruments come on the right side, which is the lower portal, and the endoscope comes on the left side. But if you have a right-sided problem, right-sided disc herniation or something where you need to approach from the right side, the thing remains the same, that your working hand goes on the left side. So your entire surgery, the kerison and everything comes on the left hand, and the right hand, which is the dominant hand, it continues to hold the endoscope. So it's very difficult because both the hands are occupied and both of them, they are doing different things. So it will be very difficult, especially I think this is the problem with most people, except for the very experienced ones, the Korean ones. I think most people, they are, they are very, difficult for them to do a right-sided approach. I've had experience. I've done a lot of UBs in my early stages, but with time, I think when I compare both the techniques together, I personally feel that with experience, definitely full endoscopy is much more easier as compared to what most people say, that it's much more easier and less invasive. See, the docking of the working channel for full endoscopy takes hardly 3 or 4 shoots of C-arm, and it is less than 2 or 3 minutes for me to dock the for the endoscope to go inside. And the amount of marking of the incisions and those things for UB is much more. So this is
I would like to disagree with only one point. Yes, I do agree that it is more invasive as far as the uniportal surgery is concerned. But the right-sided thing, it's just a mental block, because there are two ways of doing the right-sided approach. You can either stand on the left side of the patient, tilt the patient towards you, and go on the opposite side. So if I'm standing on left side, then I can go on the other sided interlaminar space, and the orientation will again remain the same. I can hold my scope in my left hand, the instruments will come from right hand. Secondly, you can also stand on the right side of the patient, still continue holding the scope in your left hand and the instruments in the right hand. But here, instead of docking onto the upper spinolaminal junction, you dock onto the lower spinolaminal junction, which is much easier, and you directly start peeling of the ligamentum flavum from caudal to cranial direction. So initially, yes, the last time we discussed, I had these kinds of problem, but I have done this thing now and it's very easy. I've also done a right-sided TLF, a right-sided paraspinal UBE approach. So I disagree with the right-sided approach thing. The rest of the points I completely respect.
Ketan,
Okay,
you said
Ketan,
that
Pramod, I think what we do is that it's very nice to have a difference of opinion amongst the endoscopic spine surgeons also, So I think we should move on. I'll let Dr. Ajay take a comment on this because he's been waiting since a long time, and then we move on and discuss it further if we have time. So, Dr. Ajay, any opinion or say on this?
Yeah, as a comment, just because it's an evolution, it evolved from say open to microscopic discectomy to tubular discectomy to interlaminar discectomy and UBE parallelly. So if you say more evolution, it is the interlaminar full endoscopy, what is more evolved than UBE. This is the sequence of evolution, and everything works good as long as you have got your objective. Even the open surgery works in this today also. That is not the problem. But other thing, what I would say, transforaminal is the thing which is the standout amongst all these techniques for discectomy. Nothing can match its outcome if you can deliver out the fragment. And the answer was given even by Ketan. Ketan told that the retraction, he becomes comfortable when he see the retraction and mobilization of the nerve root, which doesn't come into transforaminal at all, because that is the crux of the problem in most of the cases. Until unless it is done by an experienced person, problems are created because of the retraction.
Okay, Dr. Ajay, I think we need to move on. So that's a very good point you made, that there are more than one ways of doing a particular procedure, and giving ultimately what matters is the end outcome. So we move on, and we need you to tell us what are the limitations of this percutaneous endoscopic discectomy when not to do an endoscopic decompression. So over to Dr. Ajay Krishnan's talk, please.
Hello, everybody. The flow, to make it more concise, what I've done is I've tried to divide these things into literature. The opinion, I seeked opinion from few of the market leaders in surgery, at the same time experience of mine and philosophy of mine. For transforaminal endoscopic lumbar discectomy, this is the transforaminal approach, and you can address most of the disc prolapse through this approach under local anesthesia or any regional anesthesia, plus a moderate lateral recess stenosis or a foraminal stenosis can very well be addressed. But there are contraindications, and these contraindications were absolute contraindications 10 years back, 15 years back in the literature. Now they are relative contraindications. Extensively migrated disc herniations can be handled by a transforaminal approach like the right-sided image, wherein I can show the reach of my instruments for a highly migrated disc. Central disc herniations were a contraindications for transforaminal approach. No more. It's no more a contraindications. It can be done. But yes, skeptically for bilateral symptomatic patients. Calcified disc equally cannot be done. That was what was said. But these are clear examples of my own cases where I've decompressed and shown you the adequate decompression of the patient with excellent outcomes. Alpha S1 is again a contraindication, though trans-iliac approach is there. An interlaminar approach itself came into the practice because of the limitations of transforaminal approach for alpha S1. So these are the relative contraindications. More absolute contraindications which are there, though that also I will call as relative, because cauda equina syndrome, that is profound deficit, is a contraindication for transforaminal surgeries, but I already have publications on it, and literature has sporadic reporting as well. As when this stenosis is foraminal stenosis bilateral, you have to go bilateral, so that's why it can be said as a relative contraindication. For lateral recess stenosis, which is severe, you may find it difficult to decompress, and it takes more time. So LRS severe grades you may consider as a contraindication as of now. Instabilities, obviously patients who are symptomatic for their instabilities with back pains should not be addressed by transforaminal approaches. At the same time, patient factors are very much factors. Patient should be supportive enough to support you through a prone position surgery. One of the best and only absolute indication what I would say for transforaminal approaches is root abnormalities, and you should be able to identify them pre-hand, because these roots don't have mobility and you entering into a space which is already constrained, you can precipitate new things and probably give major problems. So look out for the abnormal nerve roots. Now, interlaminar thin endoscope surgery, or say stenoscopic surgery for stenosis, or say unilateral biportal endoscopy. This all is posterior endoscopy modifications and having the same indications all throughout. Almost all disc prolapse can be handled from the posterior approach by all these methods. Stenoscope makes it easy. Thin scope makes disc extraction easy, but with the thin scope, stenosis is difficult to address too. And all regions of spine can be addressed: cervical, dorsal, lumbar, everything. The limitations are more of general rather than not specific to the procedure. Yes, when you are going from posterior, you should avoid aggressive discectomy, things which usually people end up doing and create new recurrences. The only thing which my experience and understanding of the literature and the outcome in the posterior group is retraction of neural structures is unavoidable and can lead to deficits or more residuals. So in experience hands it does work, but posterior will cause more problems than even transforaminal if you have manhandled the roots, because you have to retract the neural structure. Of course, that's why I tried to put up certain questions to few of the seniors and juniors in practice. I sent them a case and asked for opinion whether you would consider an endoscopic surgery in this patient, and that was categorized into, I sent to 10 surgeons, those who were having 3 to 10 years of experience, and juniors who had 1 to 3 years of experience endoscopy, specifically endoscopy. So the case was a 68-year-old lady presented with a history of claudication both legs and a 50 feet claudication distance since 8 months. Radiculopathy in dermatomal pattern L5 root, right side, 2 months with a VAS score of 7 out of 10, and no deficits, mechanical, no back pain. Yes, she was stopped. This is the X-ray of the patient showing standing X-rays with wedged disc. There is disc space reduction at L45. There is one grade 1 lysis also at L5S1, and the mild scoliosis is evident. And this was the MRI, which was showing significant amount of stenosis at L34 and L45 both levels. And L34 was central stenosis to lateral recess stenosis, and L45 was a central stenosis, lateral recess stenosis, and a right-sided foraminal stenosis. This was the right-sided foraminal stenosis. Colleagues, seniors, friends, and the response I got from them, from the experienced surgeon, 2 of them said that they would go for fusion at L45, and one of them said that if patient insists, then they may do a laminoforaminotomy of the right side. And one of the surgeons said that UB decompression of 2 levels would be enough, and another surgeon said that the PSLD or interlaminar stenoscopic decompression with over the top small scope foraminotomy of the L45 can be done. So this was with the experienced surgeon team who reported to me. At the same time, the junior surgeons, I'm not taking anybody's name, let's keep it apolitical, and the open MLD, microlumbar decompression at 2 levels with an open approach was suggested by 2 junior surgeons who were primarily endoscopic. At the same time, open TLIF with 4 of them. Mesonics bone scalpel, and you had done partial fascectomy with 10 mm of pars preservation. On the right side, the foramen L45, which was stenosed, there I had to go into the foramen and had to truncate the superior articular process of alpha 8 to get a adequate root decompression. And traditional methods of decompression, that is the traversing root medialization by 1 centimeter and free passage of the probe was checked to complete the decompression process if it is adequate or not. My experience and philosophy, why I myself did not do it: one, it was time, because me, I have to do a posterior endoscopic surgery. The patient would need at least 4.5 hours of surgery. The patient may not support it out, and that's why I didn't do. There were multiple pathologies and multiple level which was there. Two level pathologies that also includes a foraminal approach. So over the top decompression is needed in that case. So this clubs multiple pathologies, making it more tedious. Local and epidural anesthesia enough may not be enough for this, and I may have to go in for general anesthesia, which I avoid in all the endoscopic procedures. There was the more important thing, there was no demand from the patient towards endoscopy, and I'm a busy surgeon. 4.5 hours surgery spent on a for achieving my ego satisfaction of an endoscopic surgery, wherein I know that I can deliver an open approach surgery equally in good outcome. That was the reason I avoided in this patient, and cost is a very big factor in this group of patients. Literature, opinion, and experience and philosophy, what I just talked about, and the home take home message is that don't do endoscopy when book indications are not met. So literature support has to be good. So literature support is ever evolving, and probably 10 years down the line most of the things may be done with endoscopy. Experience and training definitely matters. Market demand is less, patient demand is less. You may not push on an endoscopy uh, if the market does not demand too much out of it. Avoid if objectives of the surgery, that is to say mechanical or stenotic component of the surgery, is not achievable by an endoscopic surgical mean. When multiple pathologies are there, well, multi-level pathologies are there, or when a lumbar stenosis is in combination existing with a lumbar disc herniation, then there are high chances that you may fail. Avoid if the patient category, because of education or the social strata or education is lower, wherein they may not support anesthesia, cost may forbid them, or they may not be ready to accept the residuals. In these cases, we should avoid the surgery, because these patients may roam around with residual symptoms, and your colleague himself may say that the symptoms are not.
So, thank you, Dr. Ajay, for this wonderful talk. It was very frank and honest, as we can see it. Just a question to the panelists over here. We frequently see patients with a little bit of listhesis, or a grade 1 listhesis, especially in a degen spine, or a little bit of scoliosis. So, what is your take on this? Do you tend to give option of a fusion versus an endoscopic or an open to these patients also, or how do you go about it, Dr. Ajay?
As of now, as a standard of treatment, the patient is offered usually a fusion, because this is to be taken by a patient who understands that endoscopy is an intermediate procedure for a escalating or progressive disorder, which is stenosis and instability. But if the patient surrenders to me and he is ready to take the same risk as I am, I would be able to decompress a grade 2 listhesis also with transforaminal route easily. It is easy and it can be possible, and they give good outcomes. Posterior surgery in itself is destabilizing. All restraints you are removing. Anterior ventral surgery, ventral to the dura, removing the bump, removing the lateral recess, you have enough space and keep the stabilizing factors of the posterior elements there itself. Yes, frank instabilities, that is to say, angular instabilities which are demonstrable, or translations which is there when there is wet facets, then it doesn't work because the mechanical factors add. But there has to be a clear differentiation as to what is mobile listhesis and stable listhesis.
So one more question going on to the other panelists like Dr. Pramod or Dr. Banod. What is your take on endoscopic fusions, especially when in cases like this? There's a lot of talk going on and a lot of cases which people are now operating with endoscopic fusions. So what is your take? What is the patient, which is the ideal patient for an endoscopic fusion? Or you would rather go in for an open fusion, Dr. Banod?
I personally am in favor of open or micro mini T-leaf fusions. I do not prefer doing endoscopic fusion.
Any particular reasons for that?
For the sake of non-availability of some cage where you can put a cage through an 8 millimeter tube and the cage can expand properly. Otherwise, with endoscope, you have a better chance of preparing the end plates. You can put your scope right inside the disc space and scrape the end plates and make them really very nice. The problem is of the size of the cage. If you use the standard expanding cages, you still need because they are 8 or 9 millimeter in basic size, which expand later. The tube which we use is 8 millimeter at this point of time for transforaminal. So you need something which is lesser in size when it goes in, and then it goes bigger. That is the challenge which I face. So that's why I do not prefer.
So on this topic of expandable cages, we have been using it in open cases, and we have seen few expandable cases collapse. Now, in an area like the lumbar spine, where the loads are so high, especially at L4-5, L3-4, L5-S1, are there any long-term studies which suggest that these expandable cages might collapse, or are they collapsing? Any reports on that, Dr. Ajay? Yeah.
See, expandable cages are made for attaining heights of the disc and indirect decompression of the foramen and the stenosis. So as long as you are doing an expandable cage for that purpose, it works. And that is the concept which is for mostly anterior surgeries and O-lifts and D-lifts. But the same concept, if you are using from the posterior surgery, you have lesser footprint of the cage. It is likely to go into the disc. In fact, even O-lifts, what we are doing, we are seeing the day one subsidence also. So I would be not very much favorable for an expandable cage from a posterior approach, though it may be claimed long-term results are still awaited. You need more footprint. You need more wider cages. Then it may stand the pressure. And if you are expanding, it is likely that it will break the end plate and go in. And most of these patients are already 55, 60, 65, and you are trying to do something at a narrow footprint. It is going to subside.
Go on, Ayush.
Yeah, so we do use some expandable, but when we do that, we do a complete bilateral release. We need the release from posterior to really expand. What I completely agree with you. But we really need to release it. With endoscopy, you can do it, but you need to really work.
No, yeah, Ayush, to be very frank, and because this message has to go out, because purely the loads on the lumbar spine are so high, and you're putting in a cage which normally when in an open surgery we use 12 or 14 or whatever cage it is, and if a cage of 8 millimeters is expanding, obviously it's going to collapse under those stresses. So this is just a concern. I'm not very sure. I'm not an expert.
So it's a very valid concern, and market is really pushing. Globus has launched a cage when I was in Global. From 8 it can go up to 15. It's called X TILIF. From 8 it can really expand. 8 to 15, that is what they say. But so the market is driving it actually. If you see, because we as a surgeon know, doesn't matter how much you expand. It is not going to give even with, as he rightly told, even with anterior, you get where you to put a really wide footprint cage. We don't really get if you go more than 14. That is what we have seen. So
right.
Posterior and small and doing it is like you should take it with a pinch of salt. That's what.
Right. I think we should wait for the results from the guys who are doing it, and then jump onto it. So I think we move on to the percutaneous transforaminal techniques, and we have video from Dr. Girish Datar, who's not around over here. So we will play the video and then we'll ask the other panelists regarding their finer tips and tricks. So can we have the video of Dr. Girish Datar here?
Hello, everyone. I thank the organizers for giving me this opportunity to speak on this platform. Here I'm speaking today on transforaminal full endoscopic discectomy, why and how I do it. Before we talk about why I do it, let's see a representative case here. It's a 45-year-old civil contractor who has pain in the back and both buttocks. Pain has increased since last 8 days. He's unable to walk for the last 3 days. Neurologically, his left hip flexor is grade 3 and right hip is grade 4. So from the MRI sagittal section, axial sections, you can see that there is an extruded herniation at L23 directly compressing the thecal sac. The herniation is predominantly located on the left side. Now, upper lumbar herniations have a tendency to form calcifications. So a CT scan was performed, and you can see on the axial sections that there is a calcification or maybe an osteophyte, which can be appreciated even on the L2 on the sagittal section of the CT scan. There is the lower end plate of L2. The X-rays are pretty much normal. There is no lumbarization or sacralization of the vertebra. Now, preoperative planning in upper lumbar herniations is necessary because the interpedicular distances are short and the thecal sac is full. So the thecal sac is very much close to the medial pedicular border. So it is important for us to know the extent of herniation, how creative or caudal migrated. If the herniation is located at the level of the disc, in upper lumbar herniations, usually the foramen is wide enough for you to get an access into the spinal canal. The interpedicular distance again is important because this tells us that how close vicinity we are going to be to the thecal sac with the available trajectory, that is the posterolateral trajectory that we are going to use. Now, there are two important points that we need to understand right now. One is the needle entry point or determination of the needle entry point on the skin and the docking point on the annulus. The docking point on the annulus in upper lumbar herniations, that is any herniation above L3-4, is going to be the mid-pedicular line because the thecal sac is large and in very close proximity to the medial pedicular line. In lower lumbar herniations, you can have a medial pedicular line as your docking point on the annulus. But if the herniation is beyond grade 2 herniation, the thecal sac has already been pushed more dorsally, and you may have your docking point on the annulus a little more medial than what you actually want to. So the needle docking point is important because that's the place where you're going to enter in the disc if at all you are going to do an inside out technique. Now, the skin entry point in this case is going to be dependent on the paraspinal musculature. If you have a good bulk of paraspinal musculature, then you may choose to have a posterior lateral entry point. Now, in this case, he has a good paraspinal musculature, so I have chosen the posterior lateral entry point. And the posterior lateral entry point is going to be determined by the distance from the anterior border of the disc to the posterior skin, which I have marked it as X, and translating the same distance laterally to determine the entry point on the skin. Now, the patient is usually prone on the radiolucent table with the bolster underneath the chest and the pelvis where abdomen is completely free. You can flex the knee a little bit for the comfort. The patient is usually under conscious sedation, mostly with midazolam and fentanyl. You may augment it with local anesthesia for the patient to have a comfortable procedure. Now, for the marking point on the patient, you first determine that the spinous process is well centered between the two pedicles, that there is no rotational element, and you connect all the spinous process and mark your first line. The second line is going to be at the level of the disc. So before you do that, you have to count the vertebrae, especially in upper lumbar herniations from below, that is the last mobile segment, so that you don't make a mistake with the level marking. So you mark the level of the disc, and on the lateral, mark from the anterior border of the disc to the posterior skin. which will be used. This will be the distance which will be used from the midline to the lateral part to mark your skin entry point. Now, to augment the pain relief during the procedure, uh, for the last 2 years, we've been using the medial branch block as a supplementary block. So medial branch block is done just lateral to the pedicle over the transverse process, where you can block with about 1 cc of local anesthetic. And this gives us sufficient amount of analgesia for sympathetic mediated pain, especially in patients who have chronicity. So the surface of the annulus and the PLL, which is the most painful part during the procedure, is completely blocked, whereas the nerve is still able to give you feedback. So the nerve monitoring part of the procedure is not lost when you are doing a medial branch block. So once you have identified your target point on the skin, you start, you infiltrate the skin and the subcutaneous tissue with the local anesthetic, which is a preservative-free local anesthetic, which is Xylocard. Though the action doesn't last long, but it gives you a lot of safety in case you by chance give it intravascular. So you first stop the needle at the maximum at the medial border of the or mid pedicular border, and you check your lateral for the placement of your needle on lateral. If you are in line with the disc, you may advance it into the annulus and into the disc, through the annulus into the disc. And this the final placement you can see is on the PA, it is just beyond the midline, and on the lateral, it is in the posterior 15% to 20% of the disc, which is going to be the annulus part. This is going to be the location of the herniation or the annular, what you can say, collar, where the herniation is trapped. Once you are completely intradiscal, you may perform a discography with a plain 50% diluted iohexol, about half a cc, confirm that there is no intrathecal spread. And once you confirm that there is no intrathecal spread, you can do a chromatodiscography using diluted methylene blue or indigo carmine, whatever is available. And this will help you stain the disc in case you get lost inside. The degenerated disc nuclear material will be stained by this dye. After doing your discography, you would proceed ahead by using a serial dilator to dilate the skin and the subcutaneous tissue till the annulus. So serial dilators, about 4 in size, 4 different sizes, you can put in one after the other to dilate. So the procedure essentially becomes completely painless. Once dilatation has been performed, you'll use a conical dilator directly put in on the dock on the surface of the annulus and then tap your dilator to get intradiscal. Typically, in intradiscal part, you would tap the dilator till you reach the midline on the PA and posterior 15-20% of the disc on the lateral. Now, you need to be careful here. This is the painful part of the procedure, and this is the area where patients can have some amount of back pain, but which is now taken care by the medial branch block, which we are using it. So this is also a place where the patient can have radicular symptoms. So since the patient is awake and aware, you can confirm that the patient doesn't have any radicular symptoms when you're tapping your dilator intradiscal. Over the dilator, you'll place a conical dilator, conical sleeve, conical end sleeve in such a way that the tip is at the midline on PA, and on the lateral, you are half in and half out, or just inside the disc, which is practically the part of the annulus which you are going to be interested in. Getting to the central part of the disc is not useful, and because there's no pathology in the center of the disc. The pathology is only located in the posterior part of the disc. So the first vision that you see is going to be some tissue there, which is going to be stained with blood. Now, once you clear it out, you see a herniation directly because you have landed here in the herniation. So you would do a removal of that part of the herniation. And once you clear it off, then you have to adjust your sleeve and the endoscope to see more of annulus. Now here you do a ventral annulotomy, that is you're just checking off part of the annulus which is more in the ventral surface, which will directly expose you the whole herniation and the annular rent. So after taking off part of the ventral part of the annulus, you here directly see the annulus, you see some amount of neurological structures, and you also see the herniation here and the annular rent. So this is going to be the herniation. So you start taking off the herniation bit by bit. Once you encounter bleeding like this, you know that you have opened up the epidural space. So there's going to be some oozing which is coming from the epidural space. So this is part of the herniation, that is going to be the rent. So you remove the part of the herniation here with a ronger. This discectomy part of the procedure is painless. So you take off a part of the herniation, but you still see some herniation still there. So you may use a blunt ball probe to tease out the herniation so that you can get it as ventral as possible so that you can take it out. So this is the part of the herniation which you just teased it out. Now you see most of the herniation now removed. You can see part of the disc nuclear material which is still there, small loose tissue which is essentially not causing any compression, but you still want to take it out. So you continue to do your discectomy, which is going to be just subannular. And once you take off all these loose fragments and hanging parts, you start seeing the ventral part of the dura. So you see the central thecal sac, you see the root, and you see the contralateral part. Confirm that you have reached the extent on the contralateral side. So you're practically paracentral on the contralateral side, very close to the medial pedicular border. There is sufficient amount of access on the contralateral side. So once you have taken off all the part of the herniation, the next thing is going to be confirmation. So you confirm free ventral dura with good pulsations, good cough impulse, and then you can do a nucleoplasty by shrinking a part of the nucleus and the annulus using the 4 megahertz radio frequency. After you have completed the shrinking process, then you would target the small osteophytes. To secure all the bleeders, if you think that there's some amount of oozing coming from the epidural space, you may choose to put a closed suction drain through the same track through which you have put in your sleeve and your dilator. But if there is no bleeding, you can just get your equipment out. This completes the procedure. Now here, let us see why transforaminal endoscopy in this case. Now again, we have these 3 different advantages for the surgeon, for the patient, and as far as the endoscopic technique is concerned. Now, as far as the surgeon is concerned, this is the ease of operating in depth. Superior visibility because of the high definition cameras and constant irrigation. You can achieve a good ventral decompression because most of the pathology in disc herniation is going to be ventral. And if there is no concomitant stenosis, you may have to just do a ventral decompression where trans and foraminal endoscopy is much superior. It does not void the facet joint. In very few cases, you may have to do a foraminotomy in case you don't get an access in the epidural space. Duration of surgical time is much shorter, 45 minutes on an average in most of the cases. There's no retraction of the spinal cord or thecal sac, so no iatrogenic damage. Advantages for the patient is going to be a single incision, posterior lateral incision, which is sutureless, minimal to no blood loss, absolutely, minimal to no post-operative pain. And with the analgesia that we are providing in the form of monitored anesthesia care, local anesthesia, and the medial branch block, there's no intraoperative pain also. Patients usually go home within 4 to 6 hours. Patients who are from outstation usually tend to stay overnight. Patient will be able to resume light activities very soon, and with physiotherapy within 3 weeks time, most of the things, lifestyle, they can resume. Prices are comparable as operating times are shorter, hospital stays are shorter, and price is comparable to open spine surgery. In fact, same. Advantages of endoscopic technique would be no muscle dissection creates iatrogenic damage, and third would be surgery under local anesthesia with the patient completely awake and aware, where no nerve monitoring devices are required. The patient himself is the nerve monitoring device. Thanks a lot. I'm sure I'm able to throw some light on transforaminal endoscopy, why we do it and how we do it. Thanks a lot for your attention, and thanks a lot for giving me this opportunity to speak on this platform.
So, thank you, Dr. Datar. A question to the panelists over here. When do you decide which are the cases which are not ideal for transforaminal access, especially considering the dimensions of the foramen? So, Ayush, can we start from you and then go on to the other panelists?
So you want to know when do you consider the transforaminal compared to inter? So see, how I feel it. I judge every case with my ease and my ability to tackle it. If I find it what is the in my hand, what is the least invasive way to go for it, especially when it comes to the higher lumbar disc, maybe L1 to L2, 3, where your transforaminal access is sort of less. I think the interlaminar access is small, and even when we do through tubes or open, you need to really work for the space to take out the disc and those central discs. I think transforaminal is a beautiful technique. It really makes my job easy. So it is more of a case-based approach, and it is very, I think it's very individual-centric. I judge what Dr. Sandeep Sonawne can do, but I judge it with what I can do and what I can do safely. So there are few limitations to it, but I think it is more to do with my ability to use one technique over the other and to do the case in the safest way.
Right. So may I ask Dr. Ajay over here, any specific dimensions that you look out for on the X-ray or the radiological picture? Sometimes we encounter a hypertrophied supraarticular process, or the spine is too much in lordosis, and probably we may not get enough space for us to go inside the foramen. So any particular dimensions that you look out for in cases where you plan a transforaminal scopy, Dr. Ajay? Maybe Dr. Pramod can, Dr. Pradyumna, can you answer that?
Yeah, hello. Good evening, everyone. I think the main issue for deciding and which approach you should take, by and standard, transforaminal approach is the most minimally invasive. So if you find a disc herniation, the first thing is whether I can do it transforaminally or not. So first is the herniation, how the herniation is placed, whether I will be able to reach it transforaminally. And the second, as you said rightly, is whether the neural structures, whether the foramen will permit my endoscope to go inside. So in such cases, I guess the position of the exiting nerve root is the most important thing which you should look at. So a sagittal MRI in the foramen, sagittal sections in the level of the foramen, if the nerve root is too oblong or it is overlying the disc space in the foraminal section, in that cases, you need to be very careful, because even if you are able to put the cannula as such is usually retracting the exiting nerve root. So in such cases, you should be, we have done a study also on that, on 3-dimensional MRI with the foramen dimensions. And I feel if the exiting nerve root is close in the foramen to the cannula, then the timing for transforaminal approach is very crucial. Because the cannula is retracting the exiting nerve root, you should finish the job as early as possible. If you tend to continue to place the cannula in that position for a very long time, you may tend to have exiting nerve root problems of dysesthesia or maybe even motor deficits. So exiting root is an issue.
Yeah. A question to Dr. Banod. Many times we find that there's a high iliac wing which prevents us access to the L4-5 disc also. So which are the cases, obviously we need to angulate the scope downwards by around 10 to 20 degrees. Which are the cases in which you would rather not do these transforaminal access surgeries and prefer to do something else? Dr. Manoj?
So these are all minimally invasive surgeries categories. So if I have to do a drilling of the pedicle or a lot of drilling of the undersurface of the facet to reach a severely down migrated herniation, then it reduces the charm of the minimalism. So I would rather choose the interlaminar approach in such cases than to insist to doing a transforaminal procedure. Otherwise, as Pradyumna has said, as I also said in my talk earlier, first choice of surgery is transforaminal. If it is not feasible or it requires more bone resection or it requires much more time to do a procedure, then you switch over to interlaminar, which is equally minimally invasive, if not more than that.
Right. Pramod, your take on that? I think Pramod cannot be reached. So can we move ahead, Ayush, and complete the last talk by Dr. Pradyumna, and then we can take up further queries? Yes, can we have Dr. Pradyumna's talk, please? The AV team, can we have Dr. Yeah, thank you.
Good evening. Thank you, Bombay Spine Society, for inviting me. My talk today is on percutaneous transforaminal endoscopic discectomy for migrated disc herniations. By transforaminal endoscopy, what I mean is transforaminal access, percutaneous, uniportal with working channel endoscope, and under local anesthesia. Now, when transforaminal endoscopy was first started in 1990s and early 2000, migrated disc herniations were a contraindication for transforaminal approach. But with improved technique, experience, and technology, in selected cases, migrated disc herniations can also be treated by transforaminal endoscopy. By migration, we mean where the disc herniation is lying beyond the level of the disc. So it can be a superior migration, inferior migration, or lateral migration. Again, the degree of migration can be quantified by where it is reaching. So it can be level 1, where it is parallel to the disc, level 2 or level 3, and similarly down migrated. The transforaminal axis is special and limited because of the dimensions of the foramen. So for a safe surgical access to the point, one should have adequate space in the foramen so as to pass the endoscope, and you can reach the disc herniation. More so ever, for migrated disc herniation, you should have a significant size neural foramen whereby the scope, which is not flexible, you mind well, can reach the herniation. So proper case selection to identify is necessary before you start for migrated disc herniations with transforaminal access. Now, this is a case, a 70-year-old male with left leg pain. You see here, it's an up-migrated disc herniation bordering to mostly sequestration with a slight connection to the disc. In this He had a significant amount of medical comorbidities, and the physician as well as the patient said that they would like to go in for an endoscopic discectomy under local anesthesia. So taking adequate consent from the patient that if it is not, he may have to undergo an open procedure later on. And knowing that the foramen was quite wide, even though he's a 72-year-old, we decided to plan for a transforaminal approach. Now here the herniation is lying within the canal in the axilla of the exiting root, but pressing on the traversing root. Here the approach was around 12 to 13 centimeters from the midline and targeting the mid-pedicular line in the AP X-ray and the posterior vertebral body line in the lateral X-ray. We use the round cannula in this case, and as you see, the cannula does not enter the disc and just resides over the discs. This is an endoscopic view where we are lying over the disc. This is a radiofrequency cautery which is trying to cauterize, and the cannula is translated gradually superiorly. We have entered the epidural space. The cannula itself retracts the exiting root, and here you're using the flexible forceps to dissect the fragment. And with a 2.5 mm forceps, you try to grab the fragment from the ventral aspect of the dura and remove it. In migrated disc herniations like this, usually the fragment is fragmented and you need to seek for multiple fragments until you see the epidural space which is clear and decompressed. In this case, the patient had a very good outcome. Now, this is again a 47-year-old male with left leg pain. In this, it's an up-migrated foraminal disc herniation which is compressing the exiting root and not the traversing root. This is much more easier and ideal for treatment using the transforaminal approach. We again use a serial dilator technique to place the round cannula. This is the endoscope view. The cannula is again translated cranially, retracting the exiting nerve root, and then as you reach the fragment, you remove the fragment piecemeal. Now this procedure is done under irrigation, continuous irrigations, so the field is quite good. And if there is herniation, there is bleeding, you have to use a radiofrequency cautery to cauterize it. So this is searching for all the fragments, and once you see the last fragment is removed, and then you can see the exiting nerve root clearly over there. So as we talked about up-migrated disc herniations, the story is slightly different for down-migrated disc herniations, because in down-migrated disc herniations, the disc herniations are usually abutting the medial wall of pedicle, and the pedicle as well as the superior articular process makes things very difficult to access in this zone. So in such cases, also people have tried the transforaminal access, where you may have to do a foraminoplasty, where you have to cut the undersurface of the superior articular process to make space over there and also remove part of the pedicle. So it is called as a foraminoplasty with a suprapedicular approach. Another technique which is developed is a contralateral transforaminal endoscopic discectomy. So to reach the down-migrated fragment, it is easier if you go from a cannula cranial to caudal to approach that fragment. Another peculiar technique which was developed for down-migrated disc herniation treating transforaminally, actually it is called as a transpedicular endoscopy, where you burr directly through the endoscope using a burr and remove the down-migrated fragment. The placement direction of the cannula after planning whether the cannula is going to reach there is very important. So for a up-migrated disc herniation, the cannula is placed superiorly, and for a down-migrated, it may be directed inferiorly. These are certain articles which are for your reference, which elucidate the technique very well, as well as the problems associated with treating transforaminal migrated disc herniations transforaminally. So these are all the articles which you may refer to. Now, the complication, the most important and complication is failure to remove the fragment completely. Sometimes we see that you remove the fragment partially and still the patient has got good relief of pain, which is of no problem. But if you see that the patient has pain following discectomy where you have a remnant fragment, you may have to convert from revision to an open microdiscectomy or an interlaminar approach. So where the chance is around 20 to 25%. Again, bleeding is a problem because it's an extradiscal approach, and dysesthesia because of pressure on the exiting nerve root. With problems associated with transforaminal, now using the same working channel endoscope, you can use interlaminar approach for, and now most of the down migrated disc herniations are treated through an posterior interlaminar axis rather than a transforaminal axis. In conclusion, all migrated disc herniations can be treated using percutaneous endoscopic techniques, either transforaminal or interlaminar. You have to, right case selection is the most important thing. You should have the right training. No one should go in for a migrated disc herniation is their first case. You need to have at least 50 cases where you have treated transforaminal, you have handled the scope, and then going for migrated disc herniations. Right equipment is also necessary. So you need foraminoplasty, a transpedicular approach, endoscopic drill, flexible curved forceps, side firing lasers are helpful. And an extradiscal approach requires more control of bleeding in the epidural space. So hemostasis is key to visualization. Thank you very much.
So thank you so much. So what do you see the challenges when you have to approach these cases, especially the transforaminal? There is the pre-planning. I understand is, as we all know, is very, very important, because it is when you're going to transform, you really need to plan it out before you venture into it. So how do you pre-plan this case so that you exactly end up where you want? So what is your tips and tricks regarding getting that the migrated fragment, reaching there and just grabbing it?
That's the right thing. It's one of the most important thing is, especially if there is a very large central disc. I think that's the easiest disc to treat transforaminally, because you don't have to target a particular fragment. You can just go in the medial pedicular line, and then maybe you will be able to remove the fragment. The problem comes when you are treating small paramedian disc herniations, maybe foraminal disc herniations, or migrated disc herniation, where you need to plan your approach. So in such cases, the preoperative visualization of the MRI, X-rays, and also, if possible, CT scans. Sometimes on CT scans, you realize that you have a calcified disc or a osteophyte which is there. In such cases, then you may have to alter your approach. So pre-planning using all modalities, MRI, a CT, to help you identify the exact trajectory. So the trajectory, how many centimeters you have to go from the midline, this depends on every patient, depending on his physique. At the same time, on whether it's a foraminal disc herniation, a central disc herniation. So the planning of where you want to enter and where you want to reach is most important, and that decides everything. Also, the other thing is, I think for migrated disc herniations, I never give transforaminal as my first thing. I will do it transforaminally. But most of the times it is the demand from the patient, where the patient says that, oh, no, can you do it endoscopically? So then for migrated disc herniations, always you should take, if you're treating them transforaminally, you should take consent for an open microdiscectomy. Otherwise, if the patient is not willing for an open procedure as a fallback option, I think I would not do an endoscopic procedure for him. I would do an open microdiscectomy or an interlaminar approach directly. But if I'm thinking of endoscopy for a migrated disc herniation, this is the most important prerequisite, and there the planning is the most important.
So thank you so much for your tips and tricks. And moving to the last part of our discussion, let's start with the case presentation. Dr. Sandeep Sonawane will start with his presentation. I think there's already a video recorded case which we can yeah, we can start. We can see the case, then discuss and go through the rest of it.
A very good evening to all of you. In this particular session, I would like to present a case of a dorsolumbar cox spine in a patient 37 years of age who came to us with back pain of 4 months duration. He had gait disturbances and weakness since a month or so with no bladder involvement. He had a history of pulmonary cox which was treated 2 years back with a pleural effusion. The gene expert showed presence of rifampicin resistance. The patient had a non-functional power in lower limbs, suggestive of an early cord compression. The X-rays, as you can see, showed the evidence of a paradiscal lesion at D12L1, classical cox, with no significant collapse or kyphosis or no translation. The MRI showed the presence of a paradiscal lesion at D12L1 with an anterior abscess causing cord compression. There was no significant destruction of the body. There were paraspinal abscesses which were encroaching onto the lateral recesses, destroying the lateral masses on one particular side. The CT scan confirmed the paradiscal lesion with no collapse. The structural continuity of the spine per se was intact, and the role or the presence of instability was doubtful. So here is a case of a D12L1 cox spine, and the case is open to the house for management options.
So let's bring all the panelists, and of course we are in a endoscopy session, but I think there are many ways to tackle this case, and everyone will do as he see fits. So, but from endoscopic point of view, how easy or challenging do you think it is? And other question will be: will you be able to uh, literally decompress everything? Will you choose a transfemoral approach or interlaminar approach? So these were some of the things. So let's, Dr. Pramod Lokhande is already there. Let's start with him. Your opinion, your approach, and your choices. You're muted, please.
Yeah, can you hear me now?
We can.
Hello?
Please go ahead.
Yeah, definitely. I think transformal approach in this case, and the difficulties which we face during treating infections with endoscopy are quite a few. The technique is definitely different. First of all, doing it under local anesthesia would be very difficult because of the presence of abscess around, and it's not very comfortable for the patient. So most of the times the local anesthesia doesn't work that much. Secondly is, the anatomy is not so well defined as in the case of a disc herniation. So, you put in the endoscope and all you see is a pus everywhere, and you don't see anything around. So that is again a big challenge. And the third part is, knowing the extent of, decompression. That again is a difficult thing, because sometimes it's not in this case, but especially sometimes you have those sequestrated bone fragments which come in the way. Some are loose, some are still attached to the bodies. So you don't know how much you need to remove. Are you supposed to remove everything or just keep something back? That is there. And maybe the dural sac may not be as well visualized as in degenerative conditions or disc herniations.
So, Ketan, what will you?
So Ayush, for the sake of delegates, can I share my screen and just put up an image, or maybe the video can be paused over there?
Yeah, please put the X-ray in the background so that while we're discussing the game. So, timing, Ketan, you can come in.
So can somebody see my screen now?
Yeah, we can see your screen.
Yeah, so I'm just keeping it there.
Yeah. That will be good. Yeah. So, Ketan, what do you think?
Yep.
You will tackle it. You will do. I think you do everything, but it is again your personal preference. Do you think endoscopy is a good option, or you want to do something else?
I think we should decide on what do you want to achieve in this case. If it is just the reduction of the bacterial load, getting a good sample size, decompression, then definitely all these things can be achieved via transforaminal approach. The only way to approach this particular case via an interlaminar or a UB or open approach would be if you want to treat the underlying instability, if there is any. So I think I agree 100% with what Dr. Pramod Lokande said. This is a contained abscess, so just bursting it out open, giving a good irrigation lavage, maybe after you get a good sample, and if you want to reconfirm the diagnosis, then send it for cultures, and then you put in an antibiotic in the irrigation fluid itself. So it will give you a good lavage and it will take care of pain. And just one more point to what Dr. Lokande said, we prefer using Dexmed in these cases because the local doesn't work very well there, but the patients are very comfortable if you start them on an infusion of Dexmed around 15 to 20 minutes prior. So they are quite comfortable and they tolerate the procedure very well.
So, keeping with the time, let's see what you did, Dr. Sandeep, and maybe we'll have few comments at the end of it.
Right. So can we play the second video? Right. Satyan, you wanted to ask something in the meanwhile?
Yeah, I wanted to ask this question to the whole panel. I mean, if we are only planning to do a debridement or just to get the sample, only for that purpose, that we are not actually going ahead and stabilizing it. This patient also doesn't have any neurological deficit. Is there any advantage to doing this endoscopically over just doing a, CT guided approach to get the sample there? So, are you going to get a higher bacterial load, better sample, and higher chance of getting your gene expert and cultures positive?
Of course. Because you are getting a sample through a much larger cannula, whereas the CT guided needle biopsy is a smaller dimension.
But maybe, Arun, you can probably also do it with a image guided transpedicular biopsy and you can get a sample. So maybe
that is possible. No. The question was whether endoscopy will give a higher yield or not. Of course, because your cannula is 8 millimeter and you are getting a much larger sample size.
Sure. Maybe if this was at L2-3, L1-2 level, or it would be much easier transforaminally. At D12, L1, yes, you will probably end up getting a large sample, but you can also go transpedicular and take a biopsy. In such cases, probably if you are lucky, you can probably drain the entire abscess through the transpedicular needle also.
Okay, fine. So we play on the video.
Please play the second part of the video.
So going back to the case which we discussed, here was a case of a D12 Cox with pure paradiscal abscess with anterior soft tissue cord involvement with no significant instability per se. So the options that we had in this case was to do a classical anterior decompression with an anterior reconstruction and stabilize it posteriorly, or to only deal with the neurology part of it, allow the instability to manifest itself, and the presence of a resistant lesion added another dimension to this particular management. So we went ahead with an endoscopic anterior decompression with the patient in prone position going via the far lateral approach. The rationale of this particular technique or management was the continuity, the structural continuity of the vertebral bodies with lack of obvious destruction in the middle column. We decided to address only the neurology, decompress only the cord and get the abscess and the granulation tissue out. So in the prone position, we docked the initial guide wire or the pin at the junction of the medial pedicular line with the rest of the vertebral bodies, and after confirming on the C-arm, docked the scope. So the first step was docking the scope on the granulation tissue lateral to the cord in the axil of the nerve root, and you can see at the 12 o'clock position is the cord and at the 6 o'clock position is the granulation tissue. The second step was demarcating the cord from the cuff. So after debulking the cuff, we could visualize the lateral margin of the cord, which was sort of engulfed by the granulation tissue. The third step was separating the cuff from the cord. So by gradual dissection and debulking, when the bleeding reduced, we could actually create a plane between the anterior margin of the cord and the granulation tissue, pushing the granulation tissue anteriorly and getting it out in a piecemeal manner. And the last step was separating the membrane which sort of constricts or engulfs the cord, giving rise to neurological deficit. So gradually we could separate the membrane from the anterior margin of the cord, and you can see over here we could reach right up to the opposite side. With the help of endoscopic scissors and instruments, we could get the cuff out and decompress the dura quite well. Because the patient was an MDR Cox, we decided to supplement it with a posterior fixation. 2 weeks down the line, the patient has improved to functional power. We haven't mobilized the patient as yet. We are waiting for the culture report to start the patient on or modify the patient's second line anti-tuberculous medicines. So I think in early onset disease with purely epidural compression because of cuff or an abscess, this could be one of the modalities of management in an apparently stable lesion in the thoracolumbar or especially in the dorsal spine. Thank you very much, and I'm open to debate and discussion on this particular issue. Thank you.
So any comment from any of the panelists? Would you have done anything different? Would someone have just gone and done endoscopy and not put the screws?
In fact, I want to ask the panelist whether, this was a very well done case, but it was done under general anesthesia. And so was there a option of doing this under local with some sedation? Would that be of any benefit here?
Personally, I feel there is no need for local anesthesia. The reason for, most doctors prefer using local anesthesia for transfemoral approach. But there is a big group or big school of thought, especially the Europeans, they never use local anesthesia for endoscopic surgeries. And the main reason for using local anesthesia is probably you get those feedbacks from the patient. So maybe if you're close to the nerve root and endangering them, so in that case, the patient's feedback might be helpful. But if you're really confident about the technique and your approach towards the case, then in that case, I don't think it matters that much where what anesthesia we use. So transfemoral technique is equally safe doing it under general anesthesia. The reason I prefer to do these infection cases under general anesthesia is, first of all, you see that the amount of bleeding which was there in the field, because it's a very inflammatory area with the granulation tissue and everything bleeds. The moment you touch something, the bleeding continues to start. And we have the option of giving a hypotensive anesthesia in such patients when you're using general anesthesia. But similar things, in the lumbar spine, maybe you can supplement it with an epidural or a spinal anesthesia. But what about the thoracic spine? You can't do that. So using general anesthesia in such cases, I feel is very important. Secondly, I think we could have, if you look at the preoperative MRI pictures, the end plates were quite intact. So I think there is a good possibility these kind of patients, they would just do very well just with local debridement, drainage of the abscess rather than fusion. So I've done quite a few cases like this and with good results. So I think I would have skipped the instrumentation part in this patient.
I agree, Pramod. That was the concern in my mind also. But in this case, because the patient was already on AKT initially and we are suspecting resistant lesion, so just to be on the safe side, I put in screws so that it shouldn't collapse further. The second option was that to do an MIS and then put in screws. But to be very frank, in infection cases, I really don't prefer MIS screws. I prefer a good, if at all we are putting in instruments, better to put in open instruments and graft the posterior tensile surface also. Because again, you never know, only instruments might fail, especially if the patient lands up in kyphosis. So again, that was a concern, but it's a debatable call, yes.
If I may ask another question, and maybe Dr. Ketan Deshpande or Dr. Arun Bhanot can answer. In inflammatory conditions like TB, you're going to get a lot of bleeding, and controlling that bleeding in endoscopic would be quite challenging. So, are there any tips from your side, or what is your experience in these?
That's right. The control of bleeding in treating inflammatory infection is a big challenge. So again, as we said earlier, though you try to coagulate and cut, you try to coagulate first and then cut. So that is one thing that can save you from that, but still that is not a guarantee that you will not encounter bleeding. But if you're doing it under general anesthesia, if you can do a hypotensive anesthesia, these things can also help you. And but yes, there's no doubt in granulation tissues, whenever we treat infections, bleeding is there. Another one thing important while doing transforaminal procedures under for infections is that your needle and other instruments can pass through and through because the disc is all eaten up, it's soft, so you will not get the true resistance of other structures. So mind you that in infections it is very, very important to keep watching each advancement of your instrument, starting from your needle to guide wire to other instruments, a few millimeter by millimeter under fluoroscope.
So, for the sake of time, I think excellent case and so many learning points out of it. So, let's move to the next case by Dr. Arun Mano. Do you have the PPT or you have the recorded?
I have a PPT. I'll have to share screen.
Yeah. Please share. You can share it and we can discuss from there.
Can you see my screen now?
Yeah, we can see your screen. Go ahead, please.
So this is a case of a up-migrated sequestered herniation at L3-4. So I'll show you. This is a 44 years old male who presented with left groin and knee pain for about 3 or 4 weeks. And he was walking with a limp and in a significant degree of pain and not improving with medication. So when you examine, and the pain pattern fits into L2-3 dermatome. He had a L5, L3 hyposthesia on the left side. And as he was walking with the limb, you made him do a hopping on single leg, and he was not able to do with the left leg, whereas he was able to do the right hopping. So this is his MRI showing a significant disc herniation, which is a sequestered one, going right up to the L3 pedicle and probably upper edge of the L3 pedicle. And if you see the axial MRI, the disc herniation is lying right beside the L3 pedicle along its full length. So with this picture, I'll just take a small opinion from other panelists that what is it that they will choose and based on what reason to treat him.
So maybe
if it is a surgery.
Yeah, Pramod can go in. What will be your approach and your thought process on this case?
I think we can do this by a translaminar approach at the particular level. It's basically a modification of interlaminar approach where you actually don't land on the intervertebral space, interlaminar space. You just land on the upper lamina, make at the level of the disc, make a hole in the lamina, just extract the fragment, the sequestered fragment.
Dr. Bhanot, can you just put up the images on the screen so that for the sake of delegates? Yeah, thank you.
Yeah. Anyone else? Transforaminal Pradyumna?
No, I don't think this is possible transforaminally. If you want to ideally, if you are going to do it transforaminally, you have to do it transpedicular.
Okay.
So
you have to drill the pedicle and then do it.
yes, not possible transforaminal.
Ketan?
So what's the neurology?
He has quadriceps weakness. Left leg hopping is not possible. He's walking with a limp.
Maybe we can conserve this.
Now the option is to treat surgically now. Let's come there.
I think interlaminar approach, yeah, whichever is comfortable in your hand.
Uh-huh.
Yeah,
Anyone
Arun,
else on anything, any different opinion from the one which you have?
Arun, can I speak?
Yeah, sure.
I think another option is we definitely can use a transforaminal approach in this case. Like
right.
It's basically landing on the inferior pedicle. You don't enter the disc. Just keep on shifting the working cannula till the functional axilla. Functional axilla is the upper axilla, and you can definitely visualize this fragment. I've done a recently one case like this where the fragment was lying under the nerve root at the separation from the dura.
Mm-hmm.
So this is definitely possible, and it's a very big fragment. Definitely, it cannot be missed.
So earlier, Ayush, can I move on?
Yeah, please move on.
So earlier, I would have treated these cases with transforaminal, exactly implying with the same principle that Pramod said, that I would dock my cannula at the disc first, and then just keep it floating in the epidural space and work under the exiting nerve root. And I've done a couple of cases for foot drop as well, and they have recovered. But this was a fragment which was going right up to the upper edge of the L3 pedicle. So slight skeptical that maybe it is more than one fragment. Sometimes the sequestered fragments are not single one, but they may be two. And in such cases, if I miss on a fragment which is causing quadriceps weakness, I may not be doing an adequate job here. So going by this thing, I chose translaminar approach as Pramod said. So where you dock the cannula onto the lamina at the upper level. Now, if you compare the other options, the interlaminar, the UBE or the microscopy, all of them, if I have to do an interlaminar, I would have to drill a lot of lamina of the upper vertebra to reach that fragment. So it will again cut down the benefit of minimally invasive here. Whereas if we just drew a hole in the upper lamina without needing to cut the ligamentum flavum, without doing anything else, and simply precisely target it onto the fragment, then this would be the least invasive treatment for this particular patient. So that's why I chose the translaminar, where you dock the cannula right as shown here in the images. So this is the position of the cannula. And this is a small video that shows how it was done. So this is orientation. 12 o'clock is medial and 6 o'clock is lateral. You bare the lamina by shrinking the muscle tissue away. Then you start drilling a hole with the matchstick type of burr. You can see the reddish bone, which is a spongy bone. And then as you advance your drill, once you reach the anterior cortex of the lamina, you can again see the ivory white cortical bone there. So the cancellous bone has already been drilled. So, and you're drilling the anterior cortex of the lamina, and suddenly you will feel a small give way. And once you see that opening in the lamina, then you can, because the lamina is thinned out, so you can use the endoscopic Carrison to widen this hole. And then you see the lateral edge of the dura here. And because the fragment was besides the lateral edge of the dura, and now you see a small fat covering that area, and you can visualize the fragment which is sequestered. And as you visualize, you grab it and take it out. And then you can see and palpate for any residual fragment. Fortunately, in this case, this was only one large fragment, and this is the end result. So this was the single fragment that came out. And this is the post-operative MRI showing a translaminar hole. And this is the CT scan showing the hole through which this was all done. The only thing that you have to take care is that you should see where your pass, lateral edge of the pass is, and the drill should not reach or breach the pass, and that is what you have to check. Otherwise, in my opinion, this becomes the least invasive treatment for this particular type of herniation.
Very, very nicely done, an elegant surgical procedure, and the use of MIS and the benefit of MIS is what you have just demonstrated. Any comments from anyone before we move ahead?
Nice case, sir. I wanted to ask you in this type of case, what is a particular challenge that you would face, and what are the chances of complications here in this case?
So, if you see, you usually do not anticipate much challenge. The only thing is that one, you have to be very precise in drilling the hole. If you start drilling more medially or you tend to breach laterally. So, for the sake of time, I did not show certain steps where I first did delineate the lateral edge of the pass and made sure that that is kept in. There is a sufficient amount of bone stock kept preserved, because that was the only thing that could have gone wrong. The other is bleeding. We've been discussing about bleeding, that whenever we do these procedures, we always try to coagulate and then remove the tissue that we take care of. And the third one is residual fragment. These are the three things that you can miss out on. Fortunately, we didn't have anything of that kind. We were lucky.
The next question is that is this a good case amenable to being done by UBE?
So I do not treat and do more UBE. Maybe Ketan will answer this, but if you ask my opinion on it, if I have to do it with UBE, of course we'll have to drill a lot of lamina first to reach that area, and that is precisely my negative for choosing even the interlaminar approach in this case. Ketan, your say.
Yes, sir, as you have already mentioned, but a translaminar approach by UB is also possible. Personally don't have any experience of this sort.
The same can be done with the UB with the translaminar.
Yes. The only thing you will have to have a burr tip which doesn't have a protection sleeve, so that you can go in more vertically and burr. Your entry points and everything will have to be managed accordingly, as you've already mentioned.
Right.
So if no comments, should we move ahead?
Yeah, we can move on to the next case. That was an excellent case, Dr. Banot. Very technically challenging and very nicely done. So next case is by Dr. Ayush. So are you going to present yourself, or you have a recording?
So can Dr. Banot just unshare his screen so that
yeah,
I can
sure.
This is a much straightforward case comparatively. I cannot see it. So once let me just open it. Compared to what you just saw, I think this is a much simpler and straightforward case. But there were some important things, so I thought I'll present it. So she was a 32-year-old female, and she presented with complete foot drop, since 2 weeks foot drop. And this is the video. You can see that on the right side there is a absolute foot drop. Neither there is neither toes are moving nor ankle. So power for both is around 2, and we thought maybe MRI L4-5 normally should be the culprit, but this is what it was. It was basically a L5S1 big superior migrated disc, and you can see it is going quite up, and almost the entire canal is filled with the disc material coming up to the superior, almost the pedicle of the L5. So this is something like looking at the amount of disc prolapse and the neurological. Already she has a good, decent neurological deficit. Do you think endoscopy approach will be worth it? Do you think anyone for maybe a fusion surgery? Any risk you see when approaching this disc endoscopically? Any opinion from the house?
So I think Ayush, regarding fusion or decompression is a separate debate altogether. Since we are in this session, I think we'll stick to this particular case. So may I ask Ketan, since in this particular case, how do you see yourself doing it? Is it a classical uniportal or biportal approach?
I would prefer doing it a biportal approach here because as the patient already has a profound neurodeficit, I want least manipulation of the nerve roots. So a wide laminotomy on the symptomatics, the ipsilateral side, and flavectomy, and then removal of the fragment with minimum handling of the neural tissue is what I would do.
Right. So one question in this case is that through a biportal, your scope is relatively fixed, right? The angulation of the scope. So
Yeah.
do you think a uniportal would be a better option because you can access or angulate the scope and the instruments via the same approach rather than doing a biportal where probably you might have to exercise a bit more of lamina to get a conical view?
It depends on the relationship of the interlaminar window with that of the disc. Here, this is an alpha S1 up-migrated disc, so already there is lordosis, and the interlaminar inclination will take me directly towards the disc fragment itself. So my scopic portal will come directly onto the lamina, some amount of laminotomy, so as to see the insertion of the ligamentum flavum would be sufficient to give me a good straight vision and a direct access with the interlaminar angulation. So I don't see any problem in this particular case.
Right. Dr. Ajay, your take on this? Or maybe we can ask Pramod.
Hello.
Hello. Hello.
Yeah, go on.
Yeah.
Dr. Pradyumna.
Am I speaking or Pradyumna is speaking?
Pradyumna, can you, Dr. Pradyumna, can you talk?
Yeah, I think this is a very good case for a L5S1 interlaminar. The only challenge over here is the size of the herniation, and it is probably fragmented. So you have to probably seek all the fragments and try to remove all the fragments. But if you are going to do it endoscopically, then L5S1 posterior uniportal endoscopy is the best, I feel.
Right. So Pramod, one question over here. Normally when we encounter a disc like this, we tease the disc and it comes, the whole thing might come easily. But in certain cases, you just get a fragment and the rest of the fragment stays back. And then the whole bleeding starts and the dura falls back. So how do you access these cases then?
First of all, this is a good case for interlaminar approach, and one of the ways of avoiding worsening of the neurology is you just cut the ligamentum flavum. You don't advance your cannula, you don't advance your endoscope. You just stay on top of the surface of the dura. The fragment is definitely visualized, and you try to remove as many fragments by staying on the surface, just with the inserting the tip of the forceps inside. So that minimizes the handling of the neural structures. So try to remove as many fragments as possible. Then once adequate fragments are removed, the dura is partially decompressed. Then you can advance the working channel inside, and then you can just probe it. You can use different instruments. We have those angled probes. Then by rotation of the cannula up and down, you are able to see superiorly. And this usually at L5S1 interlaminar space is quite wide, so I don't think that would be a problem. Definitely, I think all the fragments can be completely removed. The only thing is, after you have done adequate removal of the fragments, nearly 80% of the fragments, you need to retract the neural structures. You need to look under the dural sac, look upwards, look in the superior epidural, ventral epidural space, and search. The visualization is more important in such cases rather than just probing. Probing will not be able to, sometimes the fragment may come out, but not. But just by looking at through the endoscope with the angled lens, which is there, it is possible for us to just see the fragment everywhere in the ventral space.
A question to Dr. Banot. Now, in this case, our aim is basically root decompression. So is it possible that we just stop when we find that the root is adequately decompressed and possibly leave a couple of fragments behind, or you would rather get the whole thing out?
No. So as Pramod said, I'll just elaborate on it further. Keep the working tube on the surface, remove the fragments till the time you can start seeing a little bit of medial displacement of the nerve root if you try to probe it. Once you get to that stage, that is where the problem and that is where you may encounter bleeding as well as the solution also. So once you can mobilize the nerve tissue comfortably, then you can dock your cannula, and with the rotation of the cannula, you can control the bleeding because you can keep the bleeding points away from you. But it is very important to search under the dura because in such large multi-fragmented herniations, we have personally seen that there is a high chance of missing out the fragment unless and until you are consciously looking for them right up to the upper level where they have gone.
Okay, thank you.
And the surgery is to relieve a foot drop. So you should not be aiming at least.
You need to have complete decompression, right? Right.
Inadvertently, you may still miss, but at least you should not accept it consciously.
Right, right. So Ayush, can you just tell us what you have done ahead?
So as I agree with most of what has been said, and almost we did the same thing. We went through the interlaminar approach, and L5S1, the window was pretty good, and this is how we went. The first thing, and this is the small video, this is just to orient the medial, the cranial, and the caudal. And the first thing which I did is just once we went inside, I didn't touch the dura at all, just went lateral to it. And what I did is sorry, it went back. So I sort of decompressed the disc first. So decompress the disc means I went inside and did a discectomy, a classical discectomy without touching the neural element at all. So I opened the annulus so that debulk the disc because there's a quite big chunk of disc is still contained and part of it is migrated. So once I could debulk the disc and take out the contained part, so then what we realized is that the neural structure were pretty okay, and then we went looking for the migrated fragment. So now my neural structure is sort of moving fine, and this is your exiting nerve root at the L of the L5, which we know there's a complete foot drop, and then we went till up, and we'll just see the direction, and this is the root you can see, and even the root was pretty easy to migrate it, and then the migrated fragment I started approaching with the axilla of L5, and you can see this is where the migration has gone, and then bit by bit we started taking. So we got of course I'm probing with the RF probe, and then the one fragment comes out, then this will just come out. This is the first fragment. So till now we tried not to retract anything till I could sort of debulk the contained fragment and even take out some of the extruded fragment from the going through the axilla through the L5 root. And then once we have removed a decent amount of disc, that is the time we started mobilizing those neural elements. And this is just the first fragment coming out, you can see. And then we sort of started mobilizing and taking out. It took us after this stage at least not less than 50 minutes to find each and every fragment, to go underneath, go up, go down. So a lot of fragments came out. Not less than 20-25 fragments came out. So we kept once by this time we were able to sort of mobilize the neural element, you can see, and then we kept going everywhere, going up, down. Now is the time I am mobilizing the neural element. And we literally went to all the nooks and corners to search for each and every fragment, and it took us some time. It was sort of, I kept removing it, kept coming out. At a point you are almost bored. You are removing, and there's always something coming out. But sort of we gave time, and you can see that this is how we could remove it, and still there is another fragment which will come out now. So they were not less than 20. They were fragments which are adherent to the dura. So by this time it is dura is bit free, so we can mobilize it and take those fragments, even those were slightly adherent to the dura, and this is how it goes. And at the last we checked for, so even, these fragments are pretty stuck. So we sort of use the punch to just debulk it. And this is almost, now the roots and everything is free. Still there was a fragment just underneath the L5 root, and this was the last fragment which came out. So we literally had to sort of give a lot of time to find each and every fragment, and it was like the more fragments I could take out, there was another fragment. This is the end of it. Now you can see this is the L5 root, which was pretty mobile completely, and we have almost removed everything here. And this is, now we can see the mobility of the dura, and we, as I showed you, went underneath also. And this is the amount of fragment which you could remove. And this is immediately, this is the after surgery. Fortunately, she did pretty okay. And this is the axial scan post-op. We could remove almost everything, and she did pretty well, so much so that she started walking day one. Her power was 3+. So still there's a foot drop, but walk and the pain, everything, and you can see the anti-gravity has started coming up, and almost she is 4+ now. I think 3 weeks follow. So that was something. But I think looking into the fragment was sort of a challenging task, which everyone told. And at one point I was like almost bored out of it, looking at 20-25 fragments coming out of the disc. Thank you. That's it. Any comments from anyone?
Thank you, Ayush. Nice case. That was a complete discectomy, as we call it. How's the back pain of the patient, Ayush?
Back pain is okay. She has got relieved of the leg pain, and maybe we'll see what will happen in a year or so.
Nice.
As of now, she is a happy patient. You have taken out the leg pain, and she is walking day one. The beauty of endoscopic spine surgery.
Great. So any other, I would like to ask the other panelists, any other way in which this could have been done? There's a lot of talk about the transpedicular approach. So any take on that? The experienced guys, Dr. Banod, Dr. Pramod, the transpedicular approach for disc excisions?
The transpedicular approach is basically for removal of down migrated herniations. It is not for the removal of the up migrated herniations. You cannot approach through the upper pedicle because the exiting nerve root is there. So there's no question of transpedicular approach in this case.
Right. So any comments apart from Dr. Pramod's comments?
Yeah, I wanted to actually ask the faculty, why for a case like this, already this patient has a neurological deficit, so I understand, but isn't there a very high risk of actually causing more neural injury if you are going to do this endoscopically?
No.
Why do you say so? Because even if you are doing it by open method, you are going to handle the dura in the same way. Probably with the use of endoscope, I think the chance of handling of the neural structures is much less as compared to that what we do with open surgery. So I think I don't think it matters that much, so long as the only worry for a newcomer in endoscopy is whether he'll be able to remove all the fragments.
I think Pramod, Satyan means to say that when you're doing open, you'll be doing laminectomy and creating some space posteriorly before you handle it. So if you compare it with that particular part of the procedure, maybe yes, but then there are ways and means to circumvent it. And one of the things that Pramod has already said, that you do not introduce any instrument into the canal except the one which is going to bring the fragment out. And as in the endoscopy, we don't retract the nerve much. So in this case, we will not do even much. That is no retraction, and remove the fragments once you visualize them. And the optics will give more advantage to you so that you can not miss the fragments, which is possible even in open surgery when you do laminectomy.
Another point here was that when you actually try to take the fragment out, it may sometimes push the neural structures more medially while it is coming out if you don't have that perfect angle. So is that something which can come into play here, or not really? You can see it very well and you will be able to adjust if it is pushing the root around.
Usually no.
Okay, fine. I think we need to move on to the last case by Dr. Pramod. So Pramod, do you want to present the case or you have a video?
I'll present a case, and
Right.
it's a little different case because most of our discussion today has been limited to lumbar spine. So I thought maybe we could add something.
You can share your screen and present.
Yeah. Okay. Can you see it now?
Yeah, we can. We can.
Okay. So this is a case of C1, C2 instability in a 32 years. Sorry. Yeah. So this is a case of a C1, C2 instability in a 32-year-old male with a significant upper limb weakness in both, both the hands. The power was almost 2/5, unsteady gait, bladder was normal. And if you look at the X-rays, inflection and extension, there is the instability cannot be reduced. It is irreducible. And this is the sagittal MRI picture, which shows significant compression of the upper cervical cord with cord changes. And all these complaints have been for a long time, almost 1 year. So basically a case of irreducible C1, C2 instability with severe myelopathy. So what are the options? I mean, all of you guys are doing upper cervical spine cases, especially Sandeep. Any comments? What are the options we have?
So there are two options. One is that you put this patient on traction and see for a couple of days how it is reducing. If it is getting corrected, because there's not too much of basilar invagination, it is more of an angular deformity.
Yeah.
So there's hardly any need for a facet distraction procedure. So on traction, if it is coming partially, then all posterior probably I'll get a good reduction by rod maneuvering or trying to open up the joints and jam them. If it is fixed, then probably I would like to do an anterior release and then do a posterior fixation.
Anybody else? Ayush? Arun? Any comment?
It is irreducible, so I'll be inclined more for an anterior release in this case, and then a stabilization.
Okay. Pradyumna? So
Yeah,
these
I think
are the options. Yeah.
Sorry. Yeah, I think same as Arun. Probably anterior release and posterior fixation.
Okay, so these are the options we had. All posterior, like Sandeep said, anterior only, which some doctors, especially Dr. Sushil Patkar from Pune, he is the proponent of this technique. And the third option, anterior release and posterior fixation. So the question was, can we, I chose the third option, anterior release plus posterior fixation. And the third, and what we were really thinking was, does it have any role of endoscopy, and can we supplement? This is not a complete full endoscopic procedure, but definitely can it be an endoscopic assisted procedure? And is there any role of endoscopy in the anterior release procedure? So this is what I have done. I've done the anterior release by percutaneous endoscopy, a small incision, almost 8 millimeters in size, blunt dissection with a finger. This is insertion of the dilator, working channel, and there's the endoscope which is going inside. And this is the way how I hold the endoscope in such cases. So if you look at the left side, you see the C-arm pictures, the docking of the working channel, the probe position, and the tip of the forceps. They're working in that particular area. And if you actually see the video, this is the C1, C2 joint. After release of the longus capita, longus colli, and the anterior capsule, this is the joint. See the angle of the endoscope allows you to look inside the joint. And that's the purpose of surgery in this case was just to do the anterior release. It is possible for us to, remove the decorticate or remove the articular cartilage in the joint and put in bone grafts also, but I did not do in this case. And immediately we just flipped over in the same setting and inserted pedicle screws from behind, and that's the correction which we have got immediately post-operatively, and the patient did improve post-operatively.
So excellent case, Pramod.
Yeah, thank you.
Yeah. So just some questions. Technically, how challenging it is to reach the anterior arc, because sometimes you might have to release the longest scoli. So you probably landed up in the joint space of the C1 and C2. But superficially, how do you retract the superficial structures to go to the anterior arc of the C1?
See, reaching the anterior arch is not difficult at all. Actually, the first thing which we see most of the times is, trace the surface, anterior surface of the C1, and you just see the anterior arch there. But the real problem is, because this is a 25 degrees angled endoscope, the problem is we always look in the front. So it's difficult for us we need to rotate the endoscope in the opposite direction for us to see the joints properly, for us to identify the anatomy properly. And again, one of the things which I noticed, that it was easy for me to visualize or work on the opposite sided joint more easily as compared to the ipsilateral joint. So that was again a big struggle. I don't have too many cases of this, but just 2 or 3 cases I've done. A couple of them for infections and one for this C1, C2 instability. But it's a challenging procedure, not because of the approach, not because of the problem, but I think a need for a 0-degree angled endoscope is necessary in such procedures, especially if you don't want to miss out on the anatomy or get lost anywhere.
Do you think something like a Destandoscope, a 0-degree short scope with a little modification in the sleeves might work?
Yeah, it is possible.
Yeah. Okay, fine. So any comments on Dr. Pramod's case? Satyan or Ajay, any comments on this?
Yeah, Dr. Lokhande, excellent case. But whenever we've seen these or done these from the anterior, we were needed a lot of dissection to actually get the release. And how were you able to get so much of a dissection? How were you able to get that release properly?
See, I think reaching the longest cola is not difficult at all, because you just do a blunt dissection, and the basic high retropharyngeal approach which you do by open method is slightly complicated, where you actually you take a high just incision, submandibular incision. You see the digastric, you see the belly, and then you release the attachment, you go inside, and then you retract everything, you look for see that the hypoglossal nerve is not injured. But here the incision is at the C5-6 disc level. So you're bypassing everything. You are not going there. You're completely going under the structures. So there is no question of, damage to the hypoglossal or, other things. So you're not going through the vascular areas also. And the blunt obturator makes its own path. There is a natural separation once you get a plane between the common carotid sheath and the TO complex. That same plane can be continued upwards with a little finger, and once that plane is established, it's very easy for the obturator or the dilator to be inserted. So that directly lands up, you can directly land your working channel at C1, C2 junction. So once that is exposed, you just withdraw the cannula a little bit, put in the endoscope, look on the right and the left side, and see, look for those fibers, the shiny fibers, and you can just start cutting, then expose the joints. And again, you can cut the anterior capsule to mobilize it. So, but getting orientation in this difficult to visualize on CM areas would be slightly difficult, especially even in experienced, even with a lot of experience, there is a lot of, because first 2 approaches, it took me a lot of time to get oriented with the anatomy. So that was my biggest challenge. And if you can maybe do it with some kind of navigation kind of thing, then the procedure would be much easier, maybe less than half an hour or so.
Okay. Thank you, Pramod. Thank you very much. So I think Satyan, Ayush, do we have any more cases, Ayush, or are we done with the cases?
We are done. I think so.
Yeah, right. So thank you all faculty, and we are bang on time. We're finishing in time, which is very good for the first day of a conference. And I thank all the faculty. It was a very interesting and learning experience for me and all. And thank you very much. Over to you, Satya.
Thank you, Sandeep. Again, I want to thank all of you, all the faculty, for making this an excellent session. We've had more than 150 delegates who have been watching the session. So it has been a very a good experience from that point of view. We've been getting comments also from them. It would not have been possible without your active participation. So I want to thank you once again for taking out your valuable time and coming on for this session. So thank you, Sandeep, and thank you, Ayush, for handling the entire session brilliantly. You've been champions all along. I want to thank all our delegates and viewers for watching this, and please do log in tomorrow as well. We will be starting at 9 o'clock sharp. We again have two halls, Hall A and Hall B, and the program is listed. In Hall A, we are talking about minimally invasive fusion techniques, and in Hall B, we are talking about different types of techniques like vertebroplasties and also some extended indications of endoscopic fusions, etc. So it will be a very exciting session, and we'll also be sticking to time from 9 to 1 so that it's comfortable on a Sunday morning. So I would request all of you to log in tomorrow morning as well, and I also request our faculty, esteemed faculty, you may also log in, and it'll be great to have your inputs all along the conference. So thank you very much, and good night.
Good night. Good night, everyone.
Good night, all. Good night. Bye bye.
Chalo. Great. Recording has stopped now.
Yes, sir.
For tomorrow morning, I'll come in and log in at 8:45.
No problem, sir. Platform will be open from 8 a.m. sir.
Yeah. First of all, सुविधा थोड़े messages आ रहे थे. Some people, मैंने एक भेजा अभी आपको, उनको आपका number दिया that they were not able to log in, and some people were saying that the